Hello, my name is Juan Luis Giraldo. I'm a gynecologist, specialist in reproductive medicine, and INSUR's International Medical Director. It's my pleasure today to introduce this fourth International Symposia for our international network of gynecologists and doctors we work with all around the region. We are having today doctors and gynecologists from the United States, from Curacao, from Aruba, from Trinidad and Tobago, from Bonaire, from Suriname, from República Dominicana, from Guyana, from Costa Rica, from Venezuela, from Peru, from Ecuador, from Canada. So we're delighted to be here with you in this symposia that I believe will bring really interesting concepts in the management of infertility patients for all our allied doctors. So today we're going to have two sessions during the day. The first session is going to be about fertility surgery. So we're going to be discussing areas like isthmus cell repair, tubal fertility surgery, myomectomy, Mullerian malformations, endometriosis surgery related to infertility. So it's going to be really interesting and really practical in terms of what you as gynecologists can do, surgically speaking, for your patients. The second session is going to be about ovarian stimulation. Ovarian stimulation concepts in different areas like polycystic ovarian syndrome, intrauterine insemination, IVF, like fertility preservation, and finally we're going to talk a little bit about luteal phase support in infertility treatments. So it's going to be really complete. It's going to be in English. It's going to have subtitles in Spanish if someone needs that help. And I hope that we can have a really practical and useful day talking about fertility areas in surgery and ovarian stimulation. If you want, you can have in the commentary section, you can do your commentaries and of course your questions, and we'll get back to you answering all your questions. So again, it's my pleasure to welcome you all to this fourth International INSUR Symposia for our allied doctors all around the region, and I hope that you really enjoy it and that it is really useful for you in your daily practice with infertility patients.
Hello, how are you? Welcome to our fourth International Symposium and sixth Virtual International Symposium of the INSUR Group in Colombia. It's an honor and pleasure to be with you all, as I know we can contribute greatly to enriching your knowledge in many areas of infertility. To our Colombian colleagues who've supported us, and those from the US, Suriname, Dominican Republic, Antilles, Venezuela, and all interested parties from other Latin American countries, we hope this symposium is a success, both for us as a group and especially for your learning. Today I've been tasked with discussing idnosal and endometrium management in assisted reproduction. I'd like to begin this topic with the following analogy. Always in medicine, we tend to go from simple to complex, often forgetting to the simple often comes later. After evolving from simple to complex, we return to simplicity. I'll illustrate this journey through endometrial changes in embryo implantation. Discussing simple to complex, let's revisit endometrial dating from my generation. At 60, those of us aged 50, 70 first approached endometrial study via Neuer's dating criteria. We'll then explore molecular evaluation, gene expression, and Eidmosel's impact on implantation. Going back to Neuer's dating criteria, we're talking about the 1950s, when his initial work with 300 patients generated knowledge that lasted for decades. In studying the endometrium during the luteal phase, we perform biopsies on days 21 and 22, followed by a histopathological study to determine if the endometrium is in phase or not. This helps us decide on the best therapy to improve the patient's chances of pregnancy. As we've progressed into this century, we've moved to a more advanced and definitive approach, molecular evaluation of the endometrium. Studies from the 2011 Human Reproduction Update summarize how the endometrium is molecularly affected by various pathologies, including endometriosis, hydrosalpinx, leiomyomas, endometrial polyps, and polycystic ovary syndrome. They propose endometrial mechanisms affected primarily through altered molecular expression of HOXA1, HOXA10, HOXA11, leukemia inhibitory factor, integrins, and other molecules. These pathologies affected the endometrium in each case. In that same paper, they suggest clinical interventions for these patients based on the pathology to improve endometrial implantation. For endometriosis, they recommend excision or diathermy ablation, myomectomy for leiomyomas, and salpingectomy for hydrosalpinx. The hydrosalpinx research has an interesting background. Early studies on how hydrosalpinx and tubal blockage affected embryo implantation were based on the fluid trapped in the hydrosalpinx. They cultured mouse embryos in this fluid and found that embryos in cultures with hydrosalpinx fluid had reduced blastocyst development. This led to the solution for patients with infertility and a history of ectopic or tubal issues who needed in vitro fertilization would have much better results if a salpingectomy was performed prior to the procedure. For endometrial polyps, surgical correction via hysteroscopy is key. For polycystic ovaries, weight loss and oral hypoglycemics are crucial. For endometriosis, GnRH agonists and surgical excision are recommended. For endometritis, antibiotic therapy is vital. This condition deserves special attention as it's common to have subclinical endometritis that's hard to diagnose. Antibiotic therapy, in cases where endometritis is evident, has a positive effect on endometrial implantation. For patients with endometrial dysfunction due to ovarian hyperstimulation, nowadays if more than 10, 15 eggs are retrieved, the trend is to freeze the embryos and do a delayed transfer. This covers the molecular evaluation. Next comes gene expression, the latest development in endometrial and implantation studies. At the start of this century, IUMB proposed. In the genomic era, we could study which genes were expressed at the endometrial level during implantation. This gave us a map of which genes were overexpressed or downregulated in the endometrium during the implantation window. Following Linda Giudice's studies, the IBI group, led by Carlos Simon, Dr. Peguesa, and Jorge Callejas, presented a new way to study the endometrium by evaluating gene expression in these tissues during the implantation window. Their initial research focused on how genes were affected, which were down or upregulated during ovarian stimulation with agonists or antagonists. This led to a pioneering study in this field, which was the endometrial receptivity study, later evolving into metabolomics and microbiota research of the endometrium. All this, like any medical technique, initially experienced overvaluation and overuse. Over time, it underwent what Garner postulated. All new technology in any field of human knowledge initially rises, gets overhyped and overused, then time and evidence often lead to disillusionment, abandoning these techniques, or time establishes an appropriate productivity plateau. That's where we are now with endometrial receptivity. There's still clear evidence that all IVF patients should undergo endometrial receptivity studies. Why all this? To show we go from simple to complex and back to simple. This is where Idmosil comes in. First, let's note that cesarean rates worldwide have been increasing. This global rate wasn't available until 2011, when worldwide C-section rates were 30 to 35%. By 2018, we have more extensive global figures by region, showing that the global C-section rate is 28 to 30%. Look at our region, Asia and Central Europe, where C-section rates reach 40 to 45%. If we look more specifically at countries, this table shows C-section rates and the percentage of births in public institutions. In the column where 95% or more births are in public facilities, countries like Dominican Republic have C-section rates up to 60%, Brazil 58%, Colombia 52 to 55%, and Ecuador is around 50%. In conclusion, 50 to 60% of first-time births are C-sections, rising to 80 to 90% for IVF patients. So what's the deal with these C-sections? C-section as a cause of infertility, considering isthmocele, the defect in the C-section scar as a surgical complication, can impact the correction of this isthmocele and affect assisted reproduction therapies via hysteroscopy or laparoscopy. To provide context about the definition of isthmocele, it's a defect or recess in the cervical and isthmic region that acts as a sac or reservoir. Morris first described it in 1995, studying uteruses of women with C-section history, and today isthmocele prevalence is reported up to 52%, visible on ultrasound as a defect, an area of discontinuity in the isthmic zone of varying degrees. And we'll discuss grading soon, but it's easily detectable on an ultrasound. What risk factors increase the likelihood of isthmocele after a cesarean section? Key factors include obesity, retroverted uterus, multiple prior C-sections, and emergency C-sections after prolonged labor. Complications during the cesarean are another risk factor, such as when a patient experiences tearing. The surgical technique used during the C-section, including the debate over double layer versus single layer closure, is also important. Reabsorption, or a very ischemic structure, increases the risk of hydrocele as a scarring complication. Labor duration before C-section over 5 hours and cervical dilation above 5 centimeters before the C-section, as we mentioned earlier, or prolonged pushing phases. These are risk factors that make it more likely for a patient to develop a subsequent hydrocele. How do we diagnose it? I mentioned it before, but let's explore it a bit more. Ultrasound is the most common initial diagnostic tool. It appears as a triangular anechoic area with the apex at the front wall. I'll show you some 3D images now that make it much clearer. The defect can also appear as a mass between the bladder and lower uterine segment containing debris. Another proposed ultrasound diagnostic criterion is fluid in the uterine cavity, which can be identified in up to 42% of patients who have hydrocele. During hysteroscopy, as we enter the uterus, we get a direct view of this pocket. It appears as a wedge-shaped pocket at the cervical level, often containing inflammatory fluid or blood, surrounded by a fibrous ring. The following images show hydroceles of varying degrees. Here we see a remnant wall over 5 mm, but a clear defect is visible. This image is interesting as it shows an anechoic line indicating fluid in the endometrial cavity. Here's the hydrocele, the triangular defect, and fluid in the endometrial cavity. Hysterosonography helps classify it. There are many classification systems. In one system, severe hydrocele is when the anterior remnant wall is below 5 millimeters, and if it's under 5 or 3 millimeters, these patients will have better outcomes with isthmoplasty, or the procedure will be easier to perform laparoscopically. Other patients can be treated with hysteroscopic resection of the isthmosyle, which we'll see in some images later. This is another view using hysterosonography. Here's the cervical canal, and here's the defect where we can measure the remaining wall and classify the isthmosyle. In 3D images, we see the discontinuity at the cervico-isthmic level in frontal and lateral views, showing the defect area. What complications can arise from an isthmosyle? There are both obstetric and gynecological complications. Obstetric issues may include placenta accreta due to abnormal placentation and suture dehiscence, which could potentially lead to a uterine rupture, and ectopic pregnancies can occur in the cesarean scar area after a C-section. Gynecologically, there are several issues. Importantly, women post-C-section may experience abnormal uterine bleeding, dysmenorrhea, pelvic pain, and post-coital bleeding. Infertility is another concern which we'll discuss in more detail shortly. Endometriosis, adenomyosis, abscess formation, and higher risk of complications during gynecological procedures can also occur. What's the proposed mechanism for how this cesarean scar defect, reservoir, and inflammatory area causes infertility? Persistent menstrual blood in the defect can negatively impact cervical mucus quality, altering sperm migration and capacitation. It can affect embryo implantation due to a chronic localized inflammatory state that starts at the defect site and spreads throughout the endometrial area. Many studies show reduced fertility after C-sections, much lower than natural births. Pregnancy rates may drop by 10% in women who had C-sections compared to those with spontaneous deliveries. In conclusion, isthmosyle can be a significant cause of infertility. The hypothesis: mucus buildup seen on the right when entering the hysteroscope, which appears as an area with mucosidin deposits, the sac fundus with inflammatory zones. The solution will be to tunnel that defect and, most importantly, ablate the area and the inflammatory sac fundus to prevent that area from producing exudate that will affect sperm migration and impact endometrial implantation due to the toxic effect of this inflammatory state on the embryo and gametes. To conclude, we have a significant series of 58 cases, many of whom had previous IVF, C-sections, and underwent frozen embryo transfer. Many had secondary infertility with unexplained prior C-section, simply found as isthmosyle. From this series of 58 patients, we observed after hemoplasty a live birth rate of 45% in patients under 35 years old and a rate of 50% in patients over 35 years of age.
35 years old.
In total, 62% of IVF patients diagnosed with isthmosyle and treated via hysteroscopy had a positive pregnancy test post-surgery. What I brought today is to remind you about the endometrium at the endometrial level, how we study it from basics like endometrial biopsy to molecular and genomic studies. Remember, there are simple factors like prior C-sections that can affect future fertility. We must be aware of this condition. As takeaway points, isthmosyle is increasingly common, with C-section rates in our countries at 50 to 60%. It's a sole or associated cause of secondary infertility. Isthmoplasty is shown to restore natural fertility and yield good results in assisted reproduction patients. It's advisable to find presence of ITNA in all pre-cesarean patients with secondary infertility and correct it before starting assisted reproduction therapy. I hope you found this topic interesting and that it provided new insights. It's crucial to remember that for pre-cesarean patients with secondary infertility, we must identify ITNA. On behalf of my team, I greatly appreciate your attention to this presentation today. Thank you very much.
Hello, I'm very pleased to share with all of some points that I hope will be useful in your professional practice regarding a somewhat controversial topic, which is the surgical management of endometriosis in patients with infertility. Endometriosis is a benign pathological process characterized by the presence of histological and biological similar tissue to the endometrium outside the uterine cavity, causing a chronic and recurrent inflammatory reaction. The microscopic aspect is never identical to typical endometrial tissue due to deficient vascular perfusion. These tissues have only about 50% of the estrogen receptors compared to normal endometrial tissue. Classical studies report that 25% to 50% of infertile women have a diagnosis of endometriosis. Defining the true prevalence of the disease is changing due to the wide variability in reported range. Among patients undergoing tubal sterilization and prevalence of 1 to 7% in one undergoing tubal sterilization. In another group of women undergoing laparoscopy for infertility study, endometriosis was found in 90% to 50%. In patients with chronic pelvic pain, the prevalence is between 30% to 80%, with a 6 to 8 times more likelihood of diagnosis in women with infertility. Several theories aim to explain the pathophysiology of endometriosis, but it is currently accepted that multiple mechanisms converge. Retargeted maturation combined with altered cellular and humoral immunity contributes to the body's inability to recognize abnormal endometrial tissue. There is also a dilution in a natural killer cells, decreasing cytotoxicity against autologous endometrium. Additionally, there's a increase in leukocytes macrophages and oxidative stress in the peritoneal cavity. The theory of lymphatic and hematogenous dissemination also explains the presence of endometriosis in episiotomy of cesarean section scar. Various mechanisms are linked to infertility in endometriosis, including folliculogenesis, altered folliculogenesis, which can lead to ovulatory dysfunction. This can result in the formation of adhesions, distorting pelvic anatomy, and causing tubal obstruction. Additionally, oxidative stress alters follicular and peritoneal fluid, impaired immune functions and sperm functions, ultimately reducing fertilization and implantation rates. The fertility rate, or the number of live births per 1,000 women, is significantly impaired in patients with endometriosis, dropping from 20% in couples without the disease to 2% to 10% in diagnosis couples. The most important factor for defining treatment includes symptoms which such severe pelvic pain, difficult to manage medical, the patient age and ovarian reserve are also critical since if the reserve is low, surgery might take a back seat. If the woman has a previous endometriosis surgeries, a new surgery is unlikely to offer benefits. The presence and size of endometriomas are important, and of course, the woman or couple's desire to pursue surgery versus assisted reproductive techniques must be considered. Surgery may be considered in the following scenarios. For example, patients who reject, do not respond, or cannot tolerate medical treatment, acute abdominal pain due to tubal or ovarian torsion, or the presence of idiopathies. While medical treatment can be effective in many cases, surgical approaches require expert hands and supporting institutions with experience. Patients with a diagnosis of deep endometriosis associated with bowel obstruction or genitourinary and renal lesion and other candidates for surgery. In surgery is effective in increasing the probability of natural pregnancy, a recent Cochrane review, including 3 RCTs on peritoneal endometriosis surgeries, reported that operative laparoscopy increases the intrauterine pregnancy rate compared to diagnostic laparoscopy. It is important to clarify that these studies describe as SRM stage and 2 peritoneal endometriosis. Another meta-analysis by Hodgson showed that pregnancy rates significantly increased after surgical laparoscopy compared to placebo. One of the most controversial points is the decision to operate on patients with ovarian endometriomas. According to Alborsi and colleagues, the combined results of 8 studies showed a pregnancy rate to 43% after endometrioma surgery, and this was not significantly different for other treatments, such as combined surgery with RRT alone, or aspiration sclerotherapy plus RRT. A recent comparative study reported similar pregnancy rates after laparoscopic cystectomy, 72%, or vaporization or 6 using CU dose fiber laser, 74%. However, spontaneous pregnancy rates were higher after cystectomy, 55% versus 35%. Classical studies report that 25% to 50% of infertile women have a diagnosis to endometriosis. Defining the true prevalence of the disease is changing due to the wide variability in reported ranges. Among patients undergoing tubal sterilization, a prevalence of 1 to 7% were found. In another group of women undergoing laparoscopy for infertility studies, endometriosis was found in 9% to 50%. In patients with chronic pelvic pain, the prevalence is between 30% to 80%, with a 6 to 8 times higher likelihood of diagnosis in women with infertility. A recent meta-analysis by Casals and colleagues for the Clinic of Barcelona, including 12 studies, although no controlled, evaluated the impact of surgery before IVF. This analysis shows that the pregnancy rate per cycle is significantly higher when surgery is performed prior to IVF compared to no surgery. In other meta-view, it shows that the live birth is higher in patients who undergo surgery prior to IVF. And as we all know, something deep endometriosis surgery can be incomplete due to complications and technical difficulties. This table shows that in this case, there is also a benefit from doing the surgery, but again, I reiterate that prospective controlled study were not included, which would give a lot greater reliability in making these types of decisions. Who requires RRT after surgery? But which patient deserve RRT after surgery? The answer depends on the surgical findings and the objective evaluation of all the associated factors that I mentioned above. For this, indicators have been developed, such as the already validated endometriosis fertility index by many studies that helps us predict pregnancy rates without the need for RRT. I recommend the use of tools to help predict the probability of pregnancy. The EFI, Endometrial Fertility Index, is a simple, robust, and validated clinical tool that predicts pregnancy probability for patients after surgical study of endometriosis. A higher endometrial fertility score correlates with a higher likelihood of pregnancy, intraoperative findings for ASRM classification, and significant clinical story factors, such as age, shall all be evaluated. I want to present a treatment algorithm for an article by Rosanko, which I found very helpful as it aligns with current evidence of my daily practice. In this first algorithm, it focuses on patients with a diagnostic impression of minimal male endometriosis. If the patient experiences pain, the first choice is the medical measurement. If there is no improvement, surgical management through laparoscopy should be considered. If the fertility is diagnosed along with pain, patient should be individualized and based on their characteristics, laparoscopy surgery or assisted reproductive techniques can be the first choice. In case of infertility without pain, assisted reproductive techniques such as artificial insemination will be the first choice. For deep endometriosis, RRT is the first choice when infertility is diagnosed. If after 2 cycles or IVF there is no success, surgery should be considered. In younger pains with good ovarian reserve, surgery may be a good idea before IVF. But in older patients or those with a low reserve, cryopreservation of eggs or embryos should be prioritized before surgery. To take home, the decision to offer surgical excision of deep endometriosis lesion before RRT should be primarily guided by the patient's pain symptoms and preference. Routine surgery for ovarian endometriomas before ART is not recommended, as current evidence shows no benefit and may negatively impact ovarian reserve. Operative laparoscopy could be a treatment option for ASRM stage 1-2 endometriosis, as it improves pregnancy rates. There's no convincing evidence that operative laparoscopy for deep endometriosis improves fertility, but it may represent a treatment option in symptomatic patients. Each case should be evaluated individually. The most important takeaway: multidisciplinary evaluation in specialized centers and surgery should be performed by trained professionals. Endometriosis surgery should be a one-time or the last surgery in the patient's life. Thank you very much.
Hello, everyone. Welcome to the 4th International Virtual Symposium of INSER. My name is Dr. Sergio Tamayo. Today, we're going to talk about intramural fibroids. What's the real impact on fertility? A critical and still unsolved questions in this field is the relationship between fibroids and infertility. This issue is very important because in the developed world, there is a tendency to start family at an age when natural female fertility is in decline and the incidence of fibroids is increasing. So as a consequence, the proportion of infertile women diagnosed with fibroids is expected to rise, and obviously it's going to cause a negative effect on fertility. But this is not confirmed until now, so that's what we're going to talk in these slides. Our goals, or my purpose, is to show you how frequent it is, classify these fibroids, and understand the real impact of these fibroids on fertility. And at the end, see which one is the best decision when we have a patient with myomas or fibroids. So due to the patient's viable symptoms, this condition can be underdiagnosed. And also because until 20% of the patients are asymptomatic. So according to recently published data, about 7 to 8 out of 10 women will have a fibroid during their lifetime. But in overall, the rate does not seem to be more than 8 to 10% in patients from 30 to 40 years old. So it's also important that the prevalence of is higher in patients with infertility. So among women undergoing fertility treatments, more than 1 out of 4 patients is going to have fibroids. Although it is estimated that if all other causes of infertility are excluded from the diagnosis, fibroids might be just responsible for 2 to 3% of the cause of infertility patients. So knowing that this is the most common benign condition of the uterus, it's very important to know what to do with these patients. And also it's very important to tell you that the location and size is going to be relevant at the moment to take the clinical decision about what to do with these patients. So before we start talking about fibroids and fertility, it is necessary to make sure all of us are speaking the same language. So the classification, it can be like this, as you see in the picture. There are 3 major types of uterine fibroids. Intramural fibroids grow within the muscular uterine wall. Submucosal fibroids get into the uterine cavity, and subserosal fibroids project to the outside of the uterus. But the fecal classification is a little bit more deeply or more specific. And like the picture show us, the submucosal can be 3 of them. The type 0, that is all 100% inside of the uterus. Type 1, it is less than 50% intramural. The rest is inside of the uterus. Type 2, it has to at least 50% intramural or more. And the other ones, intramural and subserosal, will be in the group of other groups of fibroids. So type 3 are 100% intramural but contacts the endometrium. Type 4, it is 100% intramural. And type 5 will be subserosal, but it has more than 50% intramural. Type 6 will be subserosal, but less than 50% intramural. Type 7 will be subserosal, the 100%, and type 8 will be these fibers that are not exactly in the uterus. It can be at the ligaments or in other parts. So knowing this, it will help us to do better studies and also know which one of those myomas we have to treat or not. Unfortunately, there's poor attention that has been paid to the mechanism through these fibers may cause infertility. So there's a lot of mechanisms by which fibers may reduce fertility, and there has been proposed in the past. This negative effect can be mediated by alteration in the uterine cavity, causing mechanical pressure, or by occurrence of abnormal uterine contractility. More than that, there's going to be like a local inflammation that can result in a hostile environment of the endometrium. And also this is going to impair the sperm transportation and the embryo implantation process. This implantation process results from the development of the embryo and also the endometrium, both at the same time, leading to the window of receptivity. So among these endometrial expressions that are associated with successful implantation are the OX genes, the OXA10 and the OXA11 appear to be the most important. So most women with deficient endometrial expression of OXA10 and OXA11 experience reduced implantation rates. So we can ask how fibroids impair endometrial receptivity. A potential mechanism by which fibroids may influence receptivity is altering this molecular expression, including the OXA10, as we're going to see in the next slide. Available evidence has demonstrated reduced endometrial OXA10 expression in women with type 0, 1, and 2 fibroids. This finding appears to affect the endometrium globally, not just the endometrium overlying the fibroid. So this one obviously is going to affect the embryo implantation, and this doesn't happen with fibroids of type 3, 4, or more. So what does the evidence tell us about the impact of intramural fibroids on fertility? So this is very important to know before we talk about the actual evidence, because evidence linking fibroids and infertility is still controversial. Some difficulties can explain the lack of conclusive evidence. So, like you see in the image, what came first, the chicken or the egg? There are many confounding factors which do not make it easy for us to clearly demonstrate the cause of this relationship. So, infertile women most of the time doesn't have children. Having that in mind, and knowing that parity displays a remarkable protective effect on the development of fibroids, infertile women may be exposed to a higher risk of developing fibroids just because they don't have children. But also, the prevalence of fibroids increase with women's age. So knowing that the parity is associated with a reduction in the risk of fibroids, so it can be a protective factor, or fertility may be partly compromised in women with fibroids. So also fertility declines with women's age, as I told you before. These relationships is very relevant, knowing that in the modern trend in Western countries for women is to delay childbearing until their 30s or even 40s, an age which fibroids become more common. So other confounding factor is that fibroids are associated with gynecological conditions that can also cause infertility, such as endometriosis. Again, it may be difficult to discern whether fibroids have a direct detrimental effect, or conversely, whether the association with infertility is mediated by the presence of conditions that can cause or interfere with infertility. So in addition, study design are complicated by the fact that fibroids are a condition with a huge difference between each patient. It can have a different kind of size, a number of them, the location. So the effect of each tumor, it's very difficult to know exactly specific that what's going to happen in the future. And finally, most of the fibroids do not cause pain or alterations during the cycle. So most of the fibroids are not detected, at least if the patient doesn't go for regular ultrasound checkup. So even though it's not easy to properly confirm the evidence and do a proper studies with the less bias possible, this is what we have. And several meta-analyses have been done to see the impact of fibroids on fertility. Like this one, published by Samigliana in 2021, it is a systematic review and meta-analysis. They first highlight the difficulty to generate research because what we already said. And they highlight that there are just a few studies on this subject that are worth it. So what he shows in this table are the studies where women have fibroids and infertility, and shows that the presence of fibroids is a lot more frequent when the patient suffers from infertility. So they suggest a relationship, but that is not something they can verify or be sure. This may be one of the best studies with the less bias, and which has been taken into account in most of the meta-analysis to date when making decision about this topic. It was published in 2006 by Cassini. This prospective control study was performed to evaluate whether the location of the uterine fibroids may influence reproductive function in women, and whether if the removal of those fibers prior to conception can improve pregnancy rates and obviously how it goes during pregnancy. This study confirms the important role of the location of the uterine fiber in infertility, and as well as the importance of submucosal fibers removal before the achievement of pregnancy. And Pritz in 2009 they published this study, and she investigated the effect of fibers on fertility and myomectomy in improving outcomes. She published this systematic review and meta-analysis. Until this year, in 2009, probably is the best evidence that we have made to make decisions. What she found was that having fibroids without specifying their location, any fibroid, affect the rate of pregnancy, implantation, and live birth, and also increase the miscarriage rate. But she did a subgroup analysis depending on the location of the fibroids, and when only submucosal fibroids was taken into account, this outcome still persists, having less pregnancies, less live birth rate, and also more miscarriages. Analyzing only women with intramural fibroids, they appear to have decreased fertility and increased pregnancy loss compared with women without such a tumor. And subserosal myomas, it doesn't happen. So all fibroids except the subserosal ones have fertility outcomes. The next question will be if removing them, fertility can improve. So she analyzed fertility outcomes and see that removal of submucosal fibroids seems to confer benefit because increase the clinical pregnancy rates, as you see in the slide, when compared to patients that did not prefer the myomectomy. And when compared patients who did the surgery with the patients without myomas, there is no difference. But even that intramural fibroids appear to decrease fertility, the results of therapy are not clear and seems not to improve after surgery. There is an ongoing debate with conflicting results on the impact of this kind of myomas, non-cavity distorting intramural fibroids, on this natural or even outcomes in IVF. So at this point, we can ask if it is just a matter of the location or if it is a matter of the size or number of myomas that the patient has. So this study published in 2018 included 151 patients with type 3 intramural fibroids and 453 matched control subjects who underwent IVF. And the results suggest that type 3 fibroids are a negative impact on the rates of implantation, clinical pregnancy, and live birth in patients undergoing IVF. So this negative impact of type 3 fibroids is remarkable in women with type 2 fibroids, especially those that were 2 or more centimeters in size. And this study, a little bit more recent, published in 2023, concluded that 2 to 6 centimeter sized non-cavity distorted intramural fibroids have a negative effect on live birth rate and IVF, but apparently those than 2 centimeters doesn't have that kind of outcome. So what about the number? This study published in 2020 showed that when there is 2 or more fibers, there is a significant impact. And also with larger size, the greater the negative impact. And this is the most recent study published just over a month ago, and it evaluates the location, size, and number of fibers, as well as the outcome after the correction or surgery. It includes 13 studies, and the objective of this study was to check the outcome according to their location and also the number of the myomas and also the size of them. And they check after myomectomy what were the outcomes. the patients. So when fibroids were compared according to their size, even when they were small, it was evident that they affect negative effect. And the larger the size, the greater the negative impact. Myomas of any size decrease the pregnancy rate. And when the number was checked, they conclude that when there is more than one fibroid, decrease the clinical pregnancy and live birth rate. But when there is just one alone, doesn't have a negative impact. So this is the issue, to remove or not to remove. That's the question. So when the outcome is improving fertility, there is no difference. So even that I am a fan of this surgery, hysteroscopy, laparoscopic, or even open surgery, I have to agree that performing a myomectomy for the treatment of intramural fibroids expose both effective patient and doctors to a lot of risk. So benefit should be carefully balanced with the surgical risk because we don't want to make harm to these patients. Laparoscopic myomectomy exposes patients to almost 10% rate of cervical complications. The main complication includes excessive blood loss, blood transfusion, and even conversion to a hysterectomy. Another possible complication is a well-known formation of both intrauterine and intra-abdominal adhesions that in the future can be associated with severe complications like bowel obstruction and chronic pelvic pain, and also it can decrease fertility in these patients. Long-term complications include risk of uterine rupture in the next pregnancy. It can happen or during labor. It is recommended to wait also after the surgery between 12 weeks and 12 months. And this can expose the patient to age-related fertility decline. And finally, fibroid morcellation during laparoscopic surgery has been associated with serious complications. Therefore, surgical removal of these intramural fibroids, especially the small ones, should not be recommended in all of the cases. It has to be, balanced with the pros and cons with the patient. At the end, take the decision according to what both decides. So when it comes to intramural fibroids, myomectomy should not perform as a prophylactic measure prior to conception. It should be individualized since it's not harmless. But there are several cases where the patient has recurrent implantation failure, recurrent pregnancy loss, or different kind of symptoms like abnormal uterine bleeding, and we can choose to perform this surgery. If for some reason we're going to do the surgery, these are my tips. Do the type of surgery you do best. If it is submucosal, it would be better to perform a hysteroscopy. In these two articles, we highlight that now there is a possibility of mixed techniques that can reduce the risk, save time, and also money. In the one that we published in 2020, you can check the case report and see the video of the surgery for free if you want to. It is very nice and safe, a safe way to resolve small submucosal myomas. And when the myomas are intramural, we have these two options, laparoscopic versus open surgery. A critical factor influencing the choice of surgical approach is first the size and quantity of those fibroids. The open surgery approach is like an alternative to the laparoscopic surgery, but also with very good outcomes when we talk about fertility. So the type of surgical procedure appears to have no significant impact on pregnancy rate. So like I said before, do whatever you think is best and you do best. So there are other alternatives in the management of the fibroids, such as uterine, artery embolization, and ultrasound guide radio frequency. So far, the results have been good, but we must wait a little bit longer and see whether this would be the best option in some cases. So to sum up, this slide show you the take-home messages. First is that myomas are benign tumors, but despite their benign nature, fibroids can cause a complication related to decrease of fertility. Myomas, even intramural ones, regardless of their size, negatively affect fertility. The larger the fibroid, the greater the negative effect. The greater the number of the fibroids, the greater the negative effect. The closer the fibroid is to the endometrium, the greater the negative effect will be. And the surgical removal of these submucosal fibroids can improve fertility rates and pregnancy outcomes. Until now, the surgical removal of intramural and subserosal fibroids is not necessary to improve fertility outcome, but more research is needed to confirm all of this that I just told you. So if you have any questions, feel free to text me. We'll be glad to help you. Thank you very much.
Hello everyone, I'm Juan Martinez, a specialist in human reproduction. I'm based in Cartagena and part of the INSED Caribe group. Today, as we continue our symposium, I'll be discussing Müllerian anomalies. I believe this is a crucial topic as these conditions are often debated in daily practice. Which ones should be corrected, which shouldn't, and in some ways, they're alterations that aren't easy to diagnose. Even among our colleagues, there's often uncertainty about how to proceed when we encounter these Müllerian anomalies. To introduce the topic, Müllerian anomalies are malformations of female genital tracts, deviating from normal female anatomy, which can impact reproductive potential and fertility. Essentially, they're alterations in the formation, fusion, and absorption of the Müllerian ducts, which are the ducts that form during the urinary stage and help in the formation, especially of the uterus and fallopian tubes. So the fusion of Müllerian ducts and absorption failure can cause some abnormalities, like the well-known uterine septum, and others in more complex cases like uterine aplasia and certain uterine malformations. Regarding the epidemiology of these conditions, we have a global prevalence of 1 to 5%. This is what we currently have, in a way, as a possibility in the general population. There might be underreporting, which is likely because these conditions are difficult to diagnose. We may have underreporting regarding the incidence in the general population overall. They can cause, speaking of recurrent loss and Müllerian anomaly conditions, between 3 to 25% of miscarriages, and are also found in 8% of infertile women, and the most frequent cause to date remains the statistic of septate uterus or uterine septum. In Colombia, it's 2.6% in the general population. and about 8.4% in infertile women. So what are they? As we just discussed, they're alterations in the Müllerian duct's development stages affecting formation, absorption, and fusion processes. What's their etiology? It's considered multifactorial, possibly polygenic, environmental, radiation, infections, past DES use, no longer used, which could have altered organ formation years ago, and toxins. Why are they so important? They can cause infertility and are a major factor in recurrent pregnancy loss for couples trying to conceive. How does it begin? What's the embryonic stage like? This typically occurs in the genital ridge and mesonephric ducts, as we can see here. These embryonic images show the early stages where Müllerian abnormalities begin to develop. In the undifferentiated stage, before sex determination, paramesonephric ducts form vaginal primordia, while mesonephric Wolffian ducts in males form the epididymis, vas deferens, and ejaculatory ducts. It's during this embryonic period that these alterations usually start. This image shows how different conditions arise based on when alterations occur in the first 6 weeks. If it occurs in the first 6 weeks, for instance, it's likely very early and could be uterine hypoplasia or agenesis. If it happens after week 7, it might lead to a bicornuate or didelphic uterus. And if it occurs after this, around weeks 9, 12, which are still quite early, it's mainly a resolution defect, resulting in conditions like a septate uterus. Conditions like didelphic uterus are mostly fusion defects, when the two parts fail to unite. Müller's ducts. In contrast, defects around week 12 are mostly reabsorption issues. This slide shows examples of reabsorption alterations. Here we see Müller's ducts fusing towards the urogenital sinus, with the inner wall gradually reabsorbing, forming the uterus. This internal reabsorption, if incomplete, typically leads to the formation of complete or partial septa. These are known as uterine septum defects. Various classifications of Müllerian anomalies have existed since 1848, with early systems emerging in the 19th century like Young's classification, which used simple odd diagrams to illustrate uterine variations. Such as a septate uterus, bicornuate uterus, and anomalies affecting the cervix and vagina. There were other types. Let's review these classifications. We'll soon see others in line with classifications from recent years, but this one I'm showing you has been the most significant. The 1988 American Society classification was used for many years. It described certain uterine anomalies, including the arcuate uterus, a normal variant. It had difficulty as it excluded vaginal and cervical alterations, making it complex to classify some intricate malformations within this system, right? Later, attempts were made to update with new classifications, though less widely used. This is the 1988 classification I mentioned, which shows simple graphs explaining all 7 possible conditions. In 2013, the European Society created a widely used classification with 6 anomalies. It includes vagina and cervix, making it easier to differentiate complex anomalies. Recently, ACBM updated in 2016, and in 2021, a new classification based on the 1988 model was made. I'll show it next. It's dynamic and can illustrate complex alterations. Currently, we're between the 2021 and 2013 classifications. This is the 2013 European classification, which is visually straightforward. One challenge has been the acronyms, which colleagues have found difficult to use in our field. U0 refers to a normal uterus, U1 to dimorphic uteri, U2 to various states, U3 to bicornuate uteri, including complete, incomplete, and partial bicornuate, and U4 to altered hemiuteri or those with rudimentary horns. This classification looks simple, but can be tricky when reading reports without images or when viewing this diagram. This classification extends beyond U0 to U6, including cervical and vaginal abnormalities, with cervical abnormalities ranging from C0 to C4, though this isn't always the case. Plasia and dysplasia in the vagina should be normal to B4, which would be vaginalplasia. After this, discussing the uterine sector, which has been one of the most frequent and debated topics due to its impact on prognosis, effectiveness, and abortion risk. Later, ESRI, this society, and QMA also created an intermediate classification because these classifications have issues. ESRI is criticized for sometimes being overly optimistic, while ASRM tends to underestimate potential outcomes. QM developed an intermediate classification, which we see in this graph. The first is the European one, which requires an external indentation greater than 50%, an internal indentation greater than 50% with different lines from the waxy part interosseous, and in the final part of the cervix, which would be 50% of the endometrial thickness. The TUME tried to make a similar classification to the 2016 ASRM, using these measurements we see here of external indentation less than 10 mm and greater than 10 mm, and these from the 2016 ASRM, taking a slightly larger cervix of 15 mm with an angle of 90 degrees. This is the 2021 classification, divided into 9 groups as we see here, with the first 4 shown in the graph. It has the advantage of being dynamic, so while we can't do it here, if you follow the link on the page, you can move the images, especially for complex conditions, to see which one is closest to the patient's uterine abnormality. We also have the advantage that we can graph and say, in a way, this classification is much better than all the previous ones. Obviously, the 2013 version is still used in many places. The European one, I think, has adapted despite difficulties with U01, U02, etc. We're also trying to use this 2021 version in 1 or 2 groups. This graph relates to certus, which I think is good to always discuss in a very specific way. A partial certus is over a centimeter thick in the wall or certum itself, with an angle over 90 degrees. The normal one doesn't meet this criteria. For instance, an A4 would be less than a centimeter with an angle over 90 degrees, as shown in the graph on the results slide. These are the other types of certus. We're now at number 6, which would be the case of bicorporeal ones. Notice that the external indentation of the first graph is over a centimeter, and obviously it also has internal indentation. For the other one here, which could be another combination, there's also this variant of less than a centimeter. We need to correct it here. It's less than a centimeter, but greater than a full cert. This is like a mix of the alteration. Now, in this ACRM classification, which improves on previous ACRM versions, by including the vagina, we see it also shows vaginal alterations like these we're looking at, which are somewhat different septa in the vagina. They're also small blocks, and we need to watch out for that. These are the complex abnormalities from 2021, which it also classifies, allowing us to graph them, as I mentioned earlier, if one agrees with what we're seeing here. So, regarding diagnosis of Müllerian anomalies, there's always been a debate about the best diagnostic method for us to determine which one can help us identify the type of alteration we're dealing with. Clearly, we all have 2D ultrasound technology in our offices. Most ultrasound machines have this capability, and of course a transvaginal ultrasound, which only frontline doctors can perform, or a hysterosalpingography, at least to suspect the condition. In the case of a transvaginal ultrasound, we might see it when, for example, there are uterine septa, right? And some obvious alterations that can be seen if we have a good ultrasound machine. Hysterosalpingography has the drawback of not showing the outer uterine contour, but we can see internal cavity changes. Stereoscopy has the same drawback as stereosarcography. It shows the cavity, but not the uterus's external or lacerous structure. While stereoscopy and poroscopy have been used comparatively, as I'll show in upcoming slides, for different diagnostic methods, 3D ultrasound remains more robust for diagnosing Müllerian anomalies, with sensitivity and specificity similar to some MRI studies. These are the most reliable, but always keeping in mind that the person performing the study has proper training, right? To make an accurate diagnosis. For a transvaginal 3D ultrasound, they should know how to do it and use the classifications we're discussing. For MRIs done by radiologists, they should have experience in this specific study and examining Müllerian anomalies, right? Always in the diagnostic criteria when we're studying Müllerian anomalies, we must also be very careful to examine the kidneys, as 15 to 20% of cases have renal abnormalities like unilateral renal agenesis, especially with uniconnuate or didelphic uterus. This Dutch study wasn't very large. There are few studies on Müllerian anomalies that are prospective, randomized, controlled. Most are retrospective case control studies, and that's been one of the limitations of these conditions, and obviously the recommendations given with such studies. This was a multi-center, randomized, controlled, blinded study, but the sample size wasn't very large, we must admit, and it found no significant difference in primary and secondary outcomes, with the primary outcome being the live birth rate, right? This was in uterine, comparing uterine recession versus not recycling it in Pesser maneuvers. As you can see, the groups weren't large, 39 to 40 patients in the first group, and for the protocol itself, the intention to treat analysis, there were 36 and 33 patients. But we see that the live birth rate didn't change with or without resection, and clinical pregnancy, ongoing pregnancy, and even loss rates showed no significant differences. That's what this study shows us, though we must consider that the sample size wasn't very large. So what should be the diagnostic approach for different imaging techniques available for Müllerian anomalies? Comparing laparoscopy and hysteroscopy, which together are considered the gold standard for diagnosis. What did we find? We found that when comparing hysteroscopy and sonography in terms of sensitivity, specificity, positive and negative predictive values. They average about 86%. Obviously, some cases might be missed. It can help, but sensitivity and specificity aren't as high as we'd like. Regarding 2D ultrasound, compared to laparoscopy and hysteroscopy, in terms of sensitivity and specificity, we see that 2D ultrasound has a sensitivity of 67%, which isn't great, but a specificity of 98%, which is good. Positive predictive value is 94% and negative is 86%, averaging 86%. Clearly, it's a helpful study, but it's somewhat lacking in negative predictive value and sensitivity. Comparing laparoscopy and hysteroscopy to sonohysterography, we see that sonohysterography has good sensitivity, specificity, positive and negative predictive values, averaging 96.5%. For transvaginal 3D ultrasound, we see very good sensitivity and specificity. The positive and negative predictive value is good, with an accuracy of 97.6% at the end of the day. So I believe it remains one of the most useful tools among all the previous ones, right? Regarding MRI, at least in this review that looked at all these aspects, comparing it with hysteroscopy and laparoscopy, there were no studies evaluating MRI as a diagnostic tool as such, up to the date this was published. The studies include patients with a prior diagnosis of uterine anomaly under further evaluation, so I think there's no lack of data on MRI, but we do know it's a good tool and very comparable to 3D ultrasound, right? So in general, to summarize, we have that the most accurate are transvaginal 3D ultrasound, followed by sonohysterography, 2D ultrasound at 86%, hysteroscopy and hysterosonography, very similar. It helps us especially with classifying complex anomalies. I won't go into detail, but I can discuss each type specifically, unlike the tubal type we've covered extensively. A unicornuate or hemiuterus can exist alone or with a rudimentary horn on the opposite side. The rudimentary horn is usually non-communicating, rarely communicating with functional endometrium. The rudimentary horn may have a cavity, potentially causing hematometra. In these cases, we must consider the possibility of resecting the functional rudimentary horn when it causes hematometra, as it often causes patient pain or can be associated with endometriosis. Treatment of the unicornuate uterus depends on its functionality, as discussed. If non-functional, it may not require intervention, but if functional, treatment might be necessary, depending on its connection to the main cavity. 44% of cases have urinary tract malformations, so it's crucial in this condition to consider renal ultrasound, as there's a high incidence of kidney abnormalities. As mentioned, treatment depends on whether it's functional or communicating and if it causes symptoms. If so, resection may be needed to reduce morbidity. To my people, a kiss. These are the grim results regarding unicornuate uterus and its treatment, but we see good preterm birth rates, yet high rates of miscarriage and ectopic pregnancy in the horn. So when we see they're functional and communicating, potentially causing erratic bleeding or even functioning, we should consider removing it, right? So it's done, as shown in the wedge image, resecting via laparotomy or laparoscopy, which is clearly better for the patient or depending on the condition. Consider hysteroscopic endometrial ablation, which is one alternative if possible. In the case of uterus didelphys, we know it's an alteration, mainly a fusion. When the fusion of the Mullerian ducts occurs, it can also present at the vaginal level, which is important to check. In this case, when we have a vaginal septum, it's an indication to remove the bicornuate uterus. The vaginal septum can hinder effectiveness, especially if the compliant side doesn't connect to the tube functionally, like where ablation occurred, right? Treatment for bicornuate uterus depends on symptoms or obstruction, sometimes presenting as hematometra or hematosalpinx. Always check for kidney issues. 20% have renal abnormalities. Options include surgery, but Strassman metroplasty is for specific cases rarely used. With bicornuate uterus, correction isn't always needed, especially with good uterine capacity. As mentioned, always consider resection carefully. Vaginal septa are simpler to operate on, making the procedure much easier for the surgeon. A bicornuate uterus, also called bicorporeal, is linked to recurrent miscarriages and preterm births. Surgery isn't recommended. Strassman's procedure is only advised for recurrent miscarriages, but it's controversial. There's a growing trend to avoid it in these two conditions. The implantation rate for a bicornuate uterus is 11%, while IVF clinical pregnancy rates are 44%. The disease treatment rate is 12%, and in some cases it's 14%. To determine if it's necessary to perform, if it's a state of bicornuate uterus with septum, a hysteroscopic metroplasty to correct it. Not all cases require this. Obviously, a bicornuate uterus without septum may not need metroplasty, right? I mean hysteroscopy, yes, or other types like astral metroplasty. For septate uterus, as discussed earlier, we must check if it's complete or partial. The partial type remains more common, right? Between these two, transvaginal ultrasound can help detect some variants and raise suspicion. It's linked to increased risk in August for some patients, with low chance of survival in premature births due to stress on the complete septum. Hysteroscopic resection definitely improves our results in assisted reproductive techniques. I think in our group, not all, but some of us need to correct uterine abnormalities, right? The treatment is hysteroscopic correction, correct? This area is vascular, hindering implantation and embryo growth, potentially causing recurrent miscarriages in many patients. So some aspects remain debatable, like using an IUD. Whether to use one or not is still controversial. Some use estrogen and progestogen regimens after reception, others don't. Some studies show no clear benefit. Some groups also suggest after reception, at follow-up after a month or two, to check if any touch-ups are needed, or to shorten the center if initial stereoscopy missed it. Cervical atresia is common with vaginal aplasia. Pregnancy chances are low, even after vaginal reconstruction. It's linked to endometriosis and cervical tubal factors. Initial treatment is for hematometra or retrograde menstruation. Pregnancies occur after IVF and embryo transfer. Transbiometrial transfer might be an option for embryo transfer. Laparoscopy is definitely uncommon in our day-to-day practice. Uterine aplasia is rare, affecting 1 in 5,000 women, causing primary infertility. Surrogacy is an obvious alternative when there's no uterus. For this patient, there's a good pregnancy rate and cumulative success rate. It's up to 50%. This option isn't accepted in some countries. In others, it's generally accepted but requires legal guidance from a specialized lawyer. Acceptance varies by country where it's being done. Uterine transplantation, growing recently, is still considered experimental. it's a treatment option where surrogacy isn't allowed. In cases of Müllerian anomalies for IVF patients, the approach depends on the specific condition. For unicornuate uterus cases, it's preferable to transfer embryos to the uterus with a thicker endometrium, which is more often found in the right uterus in these cases. Unicornuate uterus is linked to undescended testes. This is crucial for IVF, as egg retrieval may be challenging in this condition. We must consider this carefully and plan accordingly. This graph shows our approach for different Müllerian anomalies. Planning is crucial. Before IVF, we can examine most conditions using endoscopy, 3D or 2D heart scans, and MRI for a more precise diagnosis. We also consider endometriosis, as it's often associated with these conditions. A patient with a uterus didelphys might struggle to conceive naturally, but spontaneous pregnancy is possible. Endometriosis may also be present. Accurate diagnosis helps improve outcomes in assisted reproduction techniques. For unicornuate uterus, removing the rudimentary horn if functional will likely improve prognosis. For septate uterus, correcting the vaginal septum will facilitate embryo transfer in both cases. In all cases, ultrasounds are crucial to detect potential kidney abnormalities. It's closely linked to many of these kidney abnormalities. During assisted reproductive techniques for unicornuate uterus, as we just discussed, carefully monitor egg retrieval, especially from ovaries, sometimes in unusual locations. For didelphic and bicornuate uterus, try to perform the procedure in the uterus with better endometrium or features. In all cases, attempt single embryo transfers, as many are linked to preterm delivery, especially due to cervical incompetence in some cases. If we transfer 2 embryos, we know it increases the risk of premature birth. Post-RF for unicornuate uterus, be vigilant of ectopic pregnancy risk, miscarriages, and address if uncorrected. In all cases, try to perform early cervical length measurements due to the increased risk of preterm birth and cervical incompetence, okay? Also, do ultrasounds for all patients, as they tend to have abnormal presentations like breech, for example, which may require intervention. Remember, some kidney disorders are linked to a higher risk of preeclampsia, right? Well, that's what I had for you today. I hope you find it useful in identifying Müllerian anomalies in your daily practice and in guiding patients on what they need, whether assisted reproduction is necessary or not, and what should be corrected and when. Thank you very much. Have a great day.
For our INSER group, it is very gratifying to share with you our 4th International Virtual Symposium on Fertility and Assisted Reproduction. Today, I'm going to talk to you about the tubal pathology, especially tubal localization by laparoscopy. First of all, it's important to remember that 35% of infertility in couples is attributable to female factors. Sexual fertility affects approximately 20% of women. The following is blockage, damage, and malfunction and damage of the tubes. The cause of this is pelvic inflammatory disease, endometriosis. Previous pelvic surgery like ectopics, for example, or planning methods, and sexually transmitted infections. Sexual sterilization is currently the most popular form of birth control. Female sterilization represents 30% of all contraceptive methods used, in equal to 200 million women in the world. There are different surgical techniques for sterilization. It's important to remember the different parts of the tubes: the interstitial, the isthmus, ampulla, infundibulus, and fimbria. There are different techniques to do a sterilization by laparotomy, like Pomeroy, Paraclamp, Irving, Uchida, Croner, spinectomy, or salpingectomy. By laparoscopy, we can do a sterilization about the techniques of Pomeroy, Filchi clips, John Ring, Hulka clips, Croner, spinectomy, or salpingectomy. In women that are less than 30 years old, the probability to present regret is 20%. 14.3% were seeking advice on methods to achieve a new pregnancy. Between 2-4% made the decision of a reversal method or an assisted reproduction technique. It's different in women that are more than 30 years old, that 60% present regret, 60% were seeking advice on methods to achieve a new pregnancy, and 0.2% made the decision of a reversal method or an assisted reproduction technique. 14 years cumulative probability of requiring reversal information depends on the age of the woman decide to do a tubal sterilization. It's like women from 18 to 24 years old, 40% requiring reversal information. In women between 20 and 30 years old, it's 50%. In women between 31 to 35 years old is 8%, and women over 35 years old is 4%. Women aged between 18 and 24 years old at the same of sterilization have 3.5 times more likely to request reversal information than those over 30 years old. Tubal ligation during an emergency cesarean section is associated with a threefold increased risk of regret and information seeking when compared to an interval delay ligation. The first tubal laparotomy anastomosis was performed in 1896. When the different techniques are evolution, like microsurgery, laparoscopy, and robotic surgery accompanied by adequate tissue management, use of non-adhesive device, and use of antibiotics allow the development of safe and effective tubal localization. The current surgical technique for tubal localization is laparoscopic surgery. There are very many advantages like minimal tissue manipulation, less postoperative admissions, short duration of postoperative stay, less pain postoperative, less bleeding, and more aesthetic. There are many indications for reconstructive tubal surgery. For example, in the ligation, the irreversible surgical sterilization is the first indication. In the case of isthmic salpingitis nodules that you can see in this picture is another indication for reconstructive tubal surgery localization. In the case of ectopic pregnancy, the best way is salpingostomy. In case of tubal adhesion and distal tubal obstruction, the best way to do a reconstructive tubal surgery is by neosalpingostomy and fibroplasty. In some cases, the patient asks about to be at peace of mind and with your body. The other indication is no acceptance of ART. for religious beliefs, for non-acceptance of frozen embryos and its subsequent implications for a live birth in the fate of safe embryos, increased risk of prenatal morbidity with ART, like preterm birth, gestational diabetes, abnormal presentation of preeclampsia, risk of ovarian hyperstimulation syndrome with ABS, or no wanting multiple pregnancy. And finally, the economic factor that limits access to assisted reproduction techniques. This systematic review evaluates the effectiveness and risk of complications of different surgical techniques for the reversal of female sterilization compared with IVF. This review includes 37 studies. The results are with anastomosis by macrosurgical laparotomy have a pregnancy rate 42%. The risk of ectopic pregnancy is 80%. Reanastomosis by macrosurgical laparotomy, the pregnancy rate is 68%, and the ectopic pregnancy is 10%. In the case of laparoscopy reanastomosis, the pregnancy rate is 65%, and the ectopic pregnancy is 5%. And in the case of robotic reanastomosis, the pregnancy rate is 65%, and ectopic pregnancy rate is 50%. You can see when you use a microsurgical, laparoscopic, and robotic, is very similar to the pregnancy rate and the risk of ectopic pregnancy. When you do a comparison about the anastomosis by laparoscopy versus laparoscopy, is no difference in overall pregnancy rate, ectopic pregnancy, nor time for surgery to pregnancy, between 6.5 months. Surgical time is longer in laparoscopy. The total cost is higher with laparotomy, and the medical training is measured with laparoscopy. The comparison with laparotomy reanastomosis with microsurgery versus laparoscopy versus robotic surgery, no difference in pregnancy rate. Robotic tubal anastomosis versus laparotomy microsurgery, pregnancy rate is no different. Ectopic pregnant in 2 studies analyzed with opposite results, one rather risk with robotic surgery and another without showing difference. Surgical time, shorter with laparotomy. Duration of hospitalization, no difference seen. Use of analgesics is higher in the laparotomy group, and the cost is higher with robotic surgery. The comparison with laparoscopy versus robotic surgery, no significant difference in pregnancy rate, ectopic pregnancy, or hospital stay. Greater surgical time in the robotic work versus laparoscopy work. And the comparison with tubal reanastomosis versus AVF is different depends on the age of the women. In women under 37 years age, tubal reanastomosis have delivery rate 72%. AVF, the rate is 52%. In women that are over 37 years old, is different. The AVF is higher, 51%, and tubal reanastomosis is 36%. With modern minimal invasive approach, you can expect pregnancy rates like this. In women from 18 to 30 years old is 73%. In women between 30 to 33 years old is 64%. And in women from 34 to 39 years old is 46%. The result of this systematic review is the full pregnancy rate after sterilization reversal was between 42% and 69%. Reported ectopic pregnant rate was 4 to 8%. The only prognostic factor that affected only to conception was the human age. The comparison between laparotomy, microsurgery, laparoscopic, and robotic surgery showed no difference in pregnancy rate. And for other women, AVF could be a more cost-effective alternative to surgical reversal of sterilization. This study is to try to show what is the principal request in sterilization reversal. In this study, death of one of the children was 65%, second marriage is 27%, and disability of one or more children is 7%. So in our clinics right now, the first reason to requiring sterilization commercially is circumambulation. The mean interval between recanalization and pregnancy was 6.5 months. In case with sterilization by the Pomeroy method, 40% conceived. In case of laparoscopic tubal ligation, 85% conceived. And none of the patients with final tubal length less than 5 centimeters conceived. So we can do recommendations to achieve success in tubal localization. The first one is age under 37 years old, no presence of other pathologies associated with female infertility, like endometriosis, addiction, adequate coital frequency, 1 to 2 times per week, adequate ovarian reserve, ligation performed with a ring or clip by laparoscopy is better, BMI less than 25, spermogram of the normal partner, post-anastomosis tubal length more than 6.5 centimeters, and it's better when it's performed by surgeons specializing in reproductive medicine. An additional aspect to have in mind is factors such as the time after the tubal ligation was performed and the location of anastomosis have not shown difference in fertility results. Analysis of prognosis factor for ectopic pregnancy is limited. There was no correlation between the possible anastomosis site and the percentage of ectopic pregnancy. Or isthmus, or ampulla, isthmus, ampulla, ampulla. Also, there was a slightly lower incidence in the isthmus anastomosis. 3 to 5 stitch initial layer is optimal to maximize patency and postoperative pregnancy rate. Another study recommends using 4 stitch in each layer to obtain successful results in terms of tubal patency and pregnancy rate. But the really important is of meticulous technique and presence by ligament of tubal segment, independent of the number of the stitch. Today, there are no studies that compare the use with no use of intra-abdominal tubal stents for performing tubal anastomosis or the possible potential for damage to the tubal mucosa and its subsequent impact on the pregnancy rate. However, some studies support the use of a stent to possibly facilitate the surgical technique to improve tubal patency and potentially increase the pregnancy rate. However, current evidence is inconclusive. There are many surgical tips. So right now we can see a video of the laparoscopic tubal localization. If we trade in the mesosalpinx, good thumbs, distal, section of the scarf, previous scarf. This case was a young ring. Could this thumb proximal stump and identify the patency of the proximal tube. Okay. Identify the mucosa, selected hemostasia with bipolar in loop patency, it's important to go in the mucosa to allow a better representation of the stumps. It's very important to get a good alignment of the both ends, the both thumbs. Hold the suture softly and cut the suture short the knot. Check the spill on the tube to avoid it, and do a new suture to avoid spill. To hold the suture with the holder of the needle, it's very important that it's soft to avoid broken the suture. And when you pull the suture, it's important to do it soft to avoid diminish the suture. Introduce the glucosa is very important in this point. To check the potency of the tube, close the serosa with the same suture, and it's very important to remove the suture by holding it by the needle to avoid loss the needle in the cavity. Introduce the suture with a 5mm needle holder as shown in the video. Through the trocar for 5mm. Check the anastomosis. And for release retention of the anastomosis, it's important to do a suture with bicoil in the mesosalpinx. This is the contrary tubes, the anesthesia. The section of the mesosalpinx is important to allow adequate visualization of the interproximal tube. So things we can use pitocin to hemostasis to avoid electricity. Again, remove the needle, holding it in this way. Release, in this case, the mesosalpinx using bicoil. And finally, we use a Guardix, like if sodium hyaluron, to avoid adhesions after the surgery. So thank you very much for your time and for your attention. I hope to see you again soon. Thank you.
and good day to everyone. Welcome to the 4th International Virtual Symposium of Group INSER. My name is Ivan Montes, and today we're going to talk about intrauterine insemination. It's a pleasure to have you here, to all of you. So, when we talk about IUI, which is intrauterine insemination, and I will refer to it through the whole presentation as IUI, we can talk about two models of treatment. The first one is when you use the sperm of the couple of the woman. The other is when you use a donor semen and you do the IUI with the donor semen. So as a definition, the IUI, it's a reproduction technique. And it's very important that we understand what does it mean, because actually you need to do something through the whole process to use this technique. And the objective of this technique is to deposit in a non-natural way a sperm in the female reproductive system. And always it's important to understand that it should be coordinated with the ovulation of your patient. We have some requirements to do it. The first one is that we have to check the tubal factor and detect or determine the patient fallopian, the fallopian tubes that are patent in the patient. This, we can do it by two ways. One is with the hysterosalpingography, or the other one in case that you need to do anything else, or there might be another diagnosis. And in that way that you need to do something else to your patient, you can do a laparoscopic surgery and determine the patent fallopian tubes of your patient. The second one is the uterine factor, and you need to check that the uterine cavity is normal. To do this, you can use the transvaginal ultrasound, also the hysterosonogram, or preferably you can use the hysteroscopy to check that the uterine cavity is completely normal, that you don't have polyps, myomas, or septums. And when we decide to do the IUI, the most common cause to do this is when you have a male factor. And why is it important to know this? Because 20% of infertility cases in the world are due to male factor. And when you want to do an IUI, you have to know that the IUI is effective for male factor. And how do you describe this? And there are two ways to do it. One is when you have a total motile count of more than 5 to 10 millions of sperms, because sometimes when you receive the spermogram, you see that the volume of the ejaculation is normal, but maybe the number of sperms might be closer to normal or below the normal levels. But you have a good motility and you have a good morphology. Or sometimes you have a good number of sperms, but low motility and good morphology, or in other cases, good number, good motility, but not that good normal, the number of normal sperms. So one way to decide when to do it or when not to do it, it's with this number that is called total motile count. And if you have more than 5 to 10 millions, the results of the IUI might be better than when you have less than 5 millions. And another way to do it is when you do a post-wash sperm count and you have more than 1 million, then you can do an IUI. The DNA fragmentation index is something that we've been using for later years, where 30% of above 30% is considered abnormal. But when you want to do an IUI, there are no differences in the pregnancy rates when you have a DNA fragmentation index above or below 30%. It's also important to note that when you have a patient that is 40 years of age or above, the risk of complications during pregnancy or after the pregnancy increases, especially related to preterm birth, spontaneous abortion, autism spectrum disorders, and infertility. And also, when you have a paternal BMI below 25, there's also a significant decrease in semen parameters. So usually when you have one of these two types of patients, you can recommend the IUI, but only if the TMC is above 5 to 10 million of sperms motor. Related to the female factor, 30 to 35% of patients with infertility are solely female factor. The rest is a combination between both. So in patients where you think that the factor of infertility might be female, you have to know that one of the most important things that we need to know is the age of the patient. Because the result of the IUI will be completely different if we have a patient of 25 or 36 or 40 years of age. And as you can see on the graphic on the right side, this is the percentage of success per insemination. And when you have a patient of 25 to 30, 35 years or almost 36, you can see that the live birth is above 10%. But when the patient is above 39, the percentage of live birth rate decreases. Also happens the same thing with pregnancy rate, where it decreases also with the age, and the miscarriage rate increases with age. So actually, when we have a patient and we're seeing the female factor and we're doing the diagnosis, the first thing that we need to do is cross a line. And that line will decide if she is able to do an IUI treatment or if she isn't. If she's above 38 years of age, we recommend that you do not do an IUI but decide to do another type of treatment. It would be better to do an in vitro fertilization treatment. The second thing is the body mass index. The patients with higher body mass index need have more medication requirements than patients that are with BMI normal. And there's an advantage in this type of patients that when you see a patient with a higher BMI or a normal BMI, there are no difference in conceiving related to the cycles, the cumulative pregnancy rate or multiple pregnancy rates. But the thing is that you might need more dosage or sometimes even more timing of the medication for patients with BMI above 25. And the third thing is the ovarian reserve, where you can do this type of treatment, the IUI, you can do it in patients with ovulatory dysfunction, especially in PCOS patients. But when you have patients with low ovarian reserve or the origin of the anovulation is hypothalamic, the results are below 5%. So we do not recommend to do in the patients with anovulation result from hypothalamic causes or from low ovarian reserve. So in which patients would you do this type of treatment? We recommend 3 types. First, again, mild male factor. When we have a TMC above 5 to 10 million of sperms or a post-wash sperm count above 1 million, you can do it. We actually recommend higher levels, but in the literature, those are the numbers that they say that below 1 million after the post-wash, the results are below 5%. Above, it can be almost like 8 to 10, almost to 15 or 20%. In cases of female factor, when the cause is ovulatory dysfunction or when you have endometriosis. But it would be better if you do the IUI in patients where the endometriosis is diagnosed on a stage 1 or 2, where the the cumulative pregnancy rate can be as high. Sorry, the pregnancy rate per cycle can be as high as 22 to 25%, versus patients who are in the stage 3 or 4 of endometriosis, the result might be below 5.6% per cycle of treatment. And also in patients with unexplained infertility, where the cumulative pregnancy rate is around 57% after 3 cycles. So when you need to decide which type of treatment you want to do with your patient during the IUI, you need to decide which medication you're going to use. And that's one of the most frequent questions that we have. Should I use clomiphene? Should I use gonadotropins? Or should I use letrozole? So I wanted to bring you a study. This study is from 2017, where they compared 2 groups, one with clomiphene and gonadotropins, the other one with letrozole and gonadotropins. The age, duration of infertility, BMI, the endometrial thickness, they're all very similar. But there's a huge difference between the clomiphene and the letrozole. You know that the clomiphene belongs to a group where there's a modulator of the estradiol receptors, and it has a positive effect in the brain related to the stimulation of the ovaries, but it has a negative effect in the endometrium and also in the cervical mucus, which means that patients with clomiphene might have lower thickness of the endometrium compared with letrozole. Another difference is that clomiphene can produce the multifollicular stimulation, different from letrozole, where you stimulate just one, might be 2 when you use the gonadotropins. So actually, when you use letrozole, patients with letrozole have better endometriums, better thickness in the endometrium of those patients before the HCG injection. And also, because the endometrium looks better, the pregnancy rates are higher than when you compare them with clomiphene. Also, because you stimulate more than one in the clomiphene group, there is a higher risk of OHSS, which means that there are higher risk of having to cancel these type of patients. And also something that was very similar is the number of cancel cycles related to the non-formation of 2 follicles of 16 millimeters in this study, which was very similar in both groups. So you think that with the clomiphene, you might have more chances of having the patient stimulated or with the follicles as you want. But in the patients with letrozole, actually, for us, it's safer to use it. And I haven't done a cycle with clomiphene in like 5, maybe 7 years, so I would recommend the letrozole. There's another study. This one is from China. It's in Fertility and Sterility, 2018, where they compared the 3 groups: clomiphene, letrozole, and gonadotropins. And as you can see, the clinical pregnancy of clomiphene, letrozole are similar than the gonadotropins, where it's higher in this type of patients. And the risks of having twin pregnancies are very high in the clomiphene group, different from the letrozole. And also with the gonadotropins, the risk of having twin pregnancies increases, which means that actually, if you don't have a lot of tools to do this, and you just have 1 or 2 tools, one of those might be the letrozole. The use of letrozole helps you have the confidence to stimulate the patient without knowing that you won't have more than 3 or 4 follicles during the process of stimulation. And how we recommend the protocol? If you're going to use clomiphene citrate, we recommend that you use it when the menstrual period comes, you do the first ultrasound. And this would be the second tool that I would recommend, because you need to know how many follicles you're going to stimulate at the beginning and also during the process of stimulation. Because usually when we have multiple pregnancies of high order, these pregnancies happen in patients where they were not follow up, where they were not followed with the ultrasound. So we recommend that you do the follow up with the ultrasound. This is one of the most important tools that you will have in your office to stimulate patients and to do the IUI. So we recommend 3 different types of protocols, but also you can mix them. So when you use clomiphene citrate or letrozole, we recommend that you start on the second day of the menstrual period and use it for 5 days and no longer than 5 days. Also, the same with the letrozole. But the gonadotropins, you know that you will need more gonadotropins, because when you stimulate for just 5 days, you won't have a dominant follicle, so you need more days. Usually, the normal patient, the ambulatory patient, takes around 10 to 14 days to respond to the gonadotropins. We recommend also that you start with the lower dosage possible. So we recommend a dosage of 37.5 units per day. And on that cycle, you should use the same dosage through the whole cycle. If the patient doesn't respond, the next cycle, you can start with a higher dosage, but not higher than 50% of the previous dosage, which means that if you used in your previous cycle 37.5, then on the second cycle, you can start with 50 units. Don't start with 75 units, because it might be a lot. And you know that especially in patients with PCOS, that the threshold to stimulate one or stimulate a lot is very, very, very thin. So you can have a completely different response with a small increase in the dosage. So this is very important. Also, when you do the IUI and you have a preovulatory follicle, that we would recommend that you measure at least 2 different measures, and you have a follicle above 18 millimeters of diameter. On that day, you can do the trigger. And we recommend that you use recombinant HCG or urinary HCG. It doesn't matter, because both of them respond very well, especially in this type of treatment, which is IUI. And 36 hours after the trigger, you should do the insemination. And always use progesterone in the luteal phase. The pregnancy test should be done 2 weeks after the test. Another question that we have a lot is, how many follicles should I see or stimulate or think about having them above 18 millimeters to do the trigger, and when should I cancel? And this is another study. I'm sorry I didn't brought the date, but this is from 2016, I think. This one, it's also very, very fun, because this one measures the multiple pregnancy rates according to the follicle number, the stimulation days, and the estradiol levels. So usually when you do IUI with the couple or donated, the results are almost the same, but a little bit higher in the donation process. Why this happened, we're not completely sure, but this might be related to the thing that the patient that uses a donor usually doesn't have a diagnosis of a female factor, which means that the pregnancy rates per cycle might be higher than in patients where they have a female factor that might be causing the infertility. But the pregnancy rates are very similar. When you have a follicle of one follicle, usually the multiple pregnancy rates are below 20%, And when you have more than 2, well, it increases. And when you have more than 5, it increases a lot. And the thing is that usually when you have multiple pregnancies, when you have more than 4, are usually triplets or 4, and that's a very high risk pregnancy. So we recommend that you cancel the cycles when you have more than 3 follicles above 18 millimeters. The stimulation length in days, well, it depends. Usually, when you have less than 5 days of stimulation, the pregnancy rates, the multiple pregnancy rates are below 20%, but also the endometrium might not be ready, especially if you use clomiphene citrate. So we recommend that you go with at least 7 to 10 days, although it might increase the risk of having multiple pregnancies. And also, if you have the possibility, you have the chances to measure the levels of estradiol before you do the trigger. Levels above 1,000 increases the risk of multiple pregnancy more than 20%. So we recommend that if you have the chances of doing the test, you should do it and read the test and decide if you prefer to cancel, or if you have more than 3 follicles, then you should also cancel. One recommendation that we also give to our doctors or doctors or specialists that work with us is that this type of treatment, you can schedule the IUI according to your agenda. This is not something that you must do at 10 p.m. on Friday. No, you can schedule this. And how you do it? We know that the ovulation process happens after 36 hours after the LH peak, the beginning of the LH peak, which means that if you trigger a patient with a follicle of 18 millimeters, 36 hours later, she will ovulate. Between 36 to 48 hours later, she will ovulate. So you can schedule this according to your agenda. You can decide if you prefer to do it maybe on a Monday, so you can trigger her on a Saturday night, or maybe you can wait another day and just do the trigger on a Sunday to do the IUI on a Tuesday. So it depends on you. Okay, it should depend on you, and you know that when you do the insemination before the ovulation, the pregnancy rates are higher than when the IUI is done after the ovulation. So you should also know this, because sometimes we've seen it before that they do the trigger maybe 48, 72 hours before, and they do it, then they do the IUI. And we know that that patient will not get pregnant on that cycle. So that's one of the recommendations. Also, you can decide not to use any trigger like HCG, but the thing is that you will not know when that patient will ovulate. So you should do, in a natural cycle, the IUI after 24 hours after the LH surge. So you should do LH tests, urinary tests, or blood tests to check the LH levels, and if are above 15, you should do the IUI. But this is very difficult, and sometimes in that type of patients, that's when you have to do it at any moment. So we recommend that you schedule the IUI according to your agenda. Another thing that also we've seen a lot, it's that on the same cycle they do a double IUI. For example, we do the trigger today, maybe a Monday, and we do an IUI Tuesday morning and Wednesday morning. And the studies haven't showed a difference in the pregnancy rates when you do a double IUI. And it's difficult for the patients, difficult for the couple's patients, and sometimes even difficult for you, for your agenda. So we do not recommend also to do a double IUI per cycle. Another question that we always have when we're going to do an IUI is how many cycles should we do? And this is another study. This one is from 2002. It's very, very well, not that very well, but 20 years ago, where it showed that the cumulative pregnancy rate per cycle increases, especially in the 3 first cycles. After those 3, the 4th, the 5th, and the 6th, then the cumulative pregnancy rate doesn't increase very much. So actually, the guidelines recommend between 3 to 6, but we recommend 3, maximum 4, maximum number of 4, because more than 4, you won't get that patient pregnant. So we recommend that you might choose a different way, maybe to do a laparoscopic surgery to find out about the fallopian tubes. Maybe the fallopian tubes have adhesions or something like that, or maybe you have different type of endometriosis that you were thinking, or in other cases, it would be better to go through the IVF process and not just keep the patient going through the IUI cycles, because the results won't be very good. And maybe this is the most important recommendation that I would give you, is that you have to manage the patient's expectations. Because usually when you think about a treatment for infertility, you think that you will get pregnant on the first try. And especially with IUI, this might not happen. The highest pregnancy rate in IUI are between 15 to 20% per cycle. So actually what you're doing, it's like you're going back through time to put that couple on the first month when they start trying to get pregnant. So you won't get higher pregnancy rates. And the cumulative pregnancy rates usually are not above 40 to 50% with 3 cycles. So actually one thing that you have to tell your patients is that this might help you. But some patients, almost half of the patients after 3 cycles, won't get pregnant. Even with 4, 5, or 6, not more than 55 or 60% will get pregnant. So that's one of my most important recommendations that I would give you. And when to use donated semen for IUI? In 3 cases. Couples where the male factor is azoospermia, women without male couple, or in patients where they have already done an IVF treatment with ICSI, and they had a failure due to male factor, but the female factors are normal, then you can go back to IUI with donated semen. I hope that this recommendation helped you a lot in your office. And if you have any other questions, well, I'm here for you. I belong to INSER, and it was a pleasure to be with you. Have a good day.
Thanks for accepting this invitation of the 4th Simposio Internacional for Fertility and Reproduction. My name is Andres Leonardo Naranjo. I am a specialist in human reproduction of INSER Colombia, and my topic is ovarian stimulation and induction in PCOS, polycystic ovarian syndrome. On the ovarian stimulation and induction, it's a treatment, basic treatment, a common treatment for women with polycystic ovarian syndrome, especially for those seeking to conceive. And everybody knows that the PCOS is a hormonal condition that can affect the correct ovulation, and proper management is crucial for alleviating symptoms and enhancing fertility. The different presentation of this pathology, the consensus of the Rotterdam speak to 3 conditions to speak how PCOS. One, morphology of the ovary in the ultrasound, polycystic, and the volume major than 10 centimeters 3 and more than 25 follicles in the count and follicular count antral. The second condition of PCOS is oligoanovulation, and the third is hyperandrogenesis clinic of biochemic. The oligoanovulation is the principal treatment. The strategies for ovarian stimulation, the first is lifestyle modification. Before initiating medical treatments, it is recommended that the woman with PCOS adopt healthy lifestyle habits, such as a balanced diet and regular exercise, which can help regulate menstrual cycles and improve ovulation. In the first interview, we need to orient the patients to take a balanced diet and less food processed, more healthy diet, and start up regular exercise every day. This is the first step for the ovarian stimulation. You should be required at nutrition and exercise. And the strategies for ovarian stimulation. The medication, the second step is the medication for inducing ovulation. And exists 3 different medications. The first, clomiphene, commercial clomid, Simakin. This oral medication helps induce ovulation by blocking estrogen receptors in the hypothalamus, that increasing the production of hormones that stimulate the ovaries. The second is letrozole, commercial Femara, originally used for the treatment of breast cancer. This medication has also been shown to be effective in inducing the ovulation in women with PCOS. And the third is the gonadotropins. In some cases, injections of gonadotropins might be recommended to directly stimulate the ovaries. The strategies for ovarian stimulation are referred low complexity, in this case clomiphene and letrozole, because of army medication that the oral take, and the high complexity is the use of gonadotropins. In the next slide, we talk about the clomiphene and letrozole. We have a strategy to the low complexity if you can do in your consult. In these strategies, that ovarian stimulation and additional therapies, the use of metformin and oral medication commonly used to treat type 2 diabetes might also be beneficial, as it can improve insulin sensitivity and help with ovulation. The 3 steps for ovarian stimulation. The first step, change some topics of the diet, and take regular exercise. This load the insulin resistance, and the other strategy is add to the management the use of metformin. The metformin, the dose is initially 500 milligrams with the lunch, and you should be increased to 850 with the lunch. One take or two today. The problem of the metformin is the secondary effects and abdominal discomfort and others. But plus the balanced diet, regular exercise, and this is the test for ovarian stimulation. You should be take good ovulation in these patients. And these considerations, monitoring ovulation is crucial, which might include ultrasounds and blood tests to check hormone levels. It is important to work closely with a fertility specialist to tailor treatment according to individual needs. And the good practice is take exam to permeability of the fallopian tubes, and take before start these strategies to stimulate the ovulation. Before take a exam to fallopian tubes and as hormones, masculine factor masculine in the spermogram, and this exam should be still good, okay? And the other considerations is the transvaginal ultrasound to follow the different strategies to induction the ovulation. Because this treatment have risk, and the principal risk is ovarian hyperstimulation, which can lead to complications. Therefore, medical follow-up is essential during the treatment. This is hyperstimulation of ovary secondary to use of gonadotropins. This is in treatment of conflicts, but the risks without the follow with ultrasound transvaginal is have a high organ pregnancy, 2, 3 or more. If you not do the different vaginal ultrasounds, you should be take 2, 3 or more follicles and take a high organ pregnancy. Here's the low complexity induction ovulation scheme. The first is clomiphene seed traps. The clomiphene seed traps block the receptor estrogens in the hypothalamus, and the hypoestrogen needs take the pulse of the generation in the pituitary gland, increase the concentration of the hormone follicular stimulation, and the ovary is stimulate to growth the follicles. This is the form of the clomiphene seed trap acts. And in this the treatment protocol in seed traps of clomiphene, the dose initial is 50 milligrams per day for 5 days. Starting then between days 2, 3, 4 until 5 of the menstrual cycle. Can be increased to 100 milligrams a day in subsequent cycles if ovulation does not occur. The mnemotechnique for this is that I start 1, 2, or 3 tablets of clomiphene seed traps, and generally we use two tablets starting between day 2 or 5 of the menstrual cycle. This is with graphic image that the citrates of clomiphene 50 to 150 milligrams a day, and I take unit of the day for 5 days. In generally, the start the 3 day to 7 days of the menstrual cycle, and after 2, 3, 4 days after the last pills, we start with the pelvic ultrasound examination ultrasound, and we lengthen the follicle. In this treatment protocol, the other medication is the letrozole, and the letrozole, the tablets are the 2.5 milligrams. And we can start 2.5, 5, or 7.5 milligrams per day for 5 days. The scheme of induction of the ovulation is similar to the citrate of clomiphene, starting between days 2 and 5 of the menstrual cycle. This is other scheme induction of ovulation with letrozole. In the menstruation, we do the first ultrasound, transvaginal ultrasound, and if you not have cysts in the ovaries, you should be start the letrozole 2, 3, 4, or 5 days. You can to start the day 2 at day 5 of this menstrual length with 1 tablet, 2 tablets, or 3 tablets, 2.5 milligrams per day, or 5 milligrams per day, or 7.5 milligrams per day for 5 days. And you should be do the ultrasound transvaginal 2 or 3 days after the last pill of letrozole. In this treatment protocol, the monitorization is crucial. Transvaginal ultrasound are around day 10, 12 to evaluate the follicular development. And you should be, this is optional, measure hormones to check the increase of LH and follicular maturation. This is an example for the ultrasound shows of the induction of ovulation. The A and the scheme B are the first ultrasound. I see the patient with the menstrual length, the first, the second, or third day of the cycle. And this is the image. This is the uterus and the endometrium, lineal endometrium, and the follicles and trials, all these less than 10 millimeters. If I take this image A, B, C, I can to start any of two medications, clomiphene citrate or letrozole, the day 3. Generally, I start 2 pills or letrozole or citrate clomiphene for 5 days. The day 3, 4, 5, 6, 7 for 5 days. And 2 or 3 days after the last take of pills, the citrate clomiphene of Femara, I do a ultrasound. In this ultrasound, the second ultrasound, DAF, I have a 3-laminar endometrium. If the endometrium takes the confirmation of 3-laminar, I know that the estrogen is acts. And the ovary and the ultrasound of the ovary, I see a follicle in growth around the 12, 15 millimeters. And after this ultrasound, I do a ultrasound 48 hours, 2 days or 3 days after of the second ultrasound, and I should be administrate the inductor of the ovulation with Ovidrel or with HCG. And the last ultrasound in my follow is a week after the trigger. A week after the trigger, we can see free fluid and the forms of sac and the disposition for ultrasound of the corpus luteum. This is a schematic form to the different ultrasounds, transvaginal ultrasound for follow the induction of the ovulation across the cycle. And in this treatment protocol, the detection of the ovulation, we can't use text to detect LH source, scheduled intercourse or artificial at the appropriate time. In this graphic, we follow the growth of the follicle to diameter to 18, 19, maybe 20, maybe 21 millimeters of diameter. And 18, 19, 20, we can prescribe the trigger. The trigger is the Ovidrel and HCG, or we can test to detect the LH source. And when I prescribe the trigger or when I detect the LH source, we recommend the scheduled intercourse, the low induction or low complexity, or when I prescribe the elegance, the ovidual, we can to prepare to artificial insemination. In this treatment protocol, post-treatment follow-up I can confirm ovulation by analyzing levels of progesterone in the luteal phase, and maybe more than 2 of progesterone is indicated to that the confirmed the ovulation. And 2 weeks after, or if menstruation is absent, we can perform pregnancy tests, and if the pregnancy test is positive, we can start the follow-up of the pregnancy. But if the pregnancy test is negative, or the menstruation is present, we can repeat these steps 3, 4, includes 6 months in the patient's anovulatorias. And this is a scheme on resume these topics. Life in the induction of the ovulation, lifestyle improvement with reduction in these patients, improve the ovulation, and if pregnant, the pregnant is absent, clomiphen or letrozole. If that obtain the pregnant, we change to our control of the pregnant. But if it's negative, BMI more than 28 plus metformin to citrato de clomiphen is better. If less than 28 letrozole. If no pregnant, the last step is gonadotropins, in vitro fertilization. The use of gonadotropin for in vitro fertilization is an induction of ovulation, the high complexity, and you should be referred to a specialized in reproduction. Now, this is other graphic that resume these topics, that a typical oral ovulation cycle timeline, and the first days of with the menstrual leg of the patient, we take up ultrasound, maybe can to take blood work if hormone follicle stimulate, LH, estrogens, HCG, progesterone, 2, 3, 4, 5 days. Now, the ultrasound in this phase of the menstrual length is see the ovaries and not take cysts. If you don't see cysts in the ovaries, you can to start the clomid or letrozole, the 3, 4 or 5 days for 5 days. And the day 10 or 12 of the cycle, you perform the second ultrasound, and you should be take a follicle in growth. 1 or 2, more than 2 most correctly. See, if you see in the ultrasound 3 or more follicles, more than 14 millimeters, the vessels cancel this cycle, and the next stimulation, you should be use less clomid or less letrozole. We typically start 2 clomiphen, 2 tablets of clomiphen, 2 tablets of letrozole. if in the second ultrasound you see hyperstimulation or more than 3 follicles, you cancel this cycle, and in the next month you should be start with one tablet. And before of the second ultrasound, 2 days after, you should take a new ultrasound. And when the growth follicle 1 or 2, the 18, 19, 20 millimeters, you can prescribe the trigger oviral or HCG and program the intercourse, the relations between the patients. And one week post the relations with this, you can take levels of progesterone. And the level of progesterone is more than 10, the ovulation is good, or more than 2. And 2 weeks after, you can take the pregnancy test. If pregnancy test is positive, change or control the pregnancy. If the pregnancy test is negative, or the patient presents you menstrual length, you can restart this scheme of induction of ovulation. And this small slides, this slide is based on the international evidence that's guideline for the assessment of and management of polycystic ovarian syndrome in the 2023, and the different societies, and specifically the Chapter 5, Assessment and Treatment of Infertility. And thank you.
Hello, everyone. It's a real pleasure for me to be with you today and talking about a very interesting topic, that is the ovarian stimulation for cycles of IVF and ICSI. My name is Dr. Espina. I'm the medical director of the clinic in Bogota, and I'll be here available for any doubt or a question that you could have around this interesting topic. Okay, let's start with this lecture today. And first of all, it's important to understand what is the definition about ovarian stimulation. And I can tell you that this is a pharmacological treatment with the intention of inducing the development of ovarian follicles. But we have 2 main purposes when we do this treatment. The first one is planning for time intercourse or insemination. And the second one is to obtain multiple oocytes at the moment of the follicular aspiration. Today, we will talk about the second point, is how can we obtain the best quality and the best quantity of eggs during a process of IVF and ICSI. If you evaluate the evidence about this topic, you will find that there is a lack of guidelines about this specific theme. Some societies has been proposed some statements, for example, the NICE guideline and the Royal College of New Zealand. And even in 2017, the WHO made a review of the evidence, but in this document, you will find no recommendations for the correct way to do the process. But in 2019, the Israel Society, who is the Society of the European Embryologists and Reproductive Medicine, they made a beautiful publication. This is in the right side of the screen, ovarian stimulation for IVF and ICSI. If anybody of you are interested in searching more deeply this theme, I will recommend you this document. Okay, it's important to remember what is the definition about infertility. And infertility is a disease, and it's important to know that. For many years ago, the WHO considered the infertility like a disease, and maybe that changed in some point the way that we look and the way that we treat the infertility. And this is a disease that could affect the male or the female reproductive system and is defined by the failure to achieve a pregnancy after 12 months or more of regular unprotected sexual intercourse. In the last year, 2023, the WHO made this publication about the prevalence of the infertility around the world. And what can we find in this document? If you see here, the prevalence as the classic concept that we have is around 12% in the general population. But in the left side of the screen here, you will see a new concept. And this new concept is the lifetime prevalence. And what is that? It means that 17.5% of the population could have or could experience some type of infertility during their lives. That means that 1 in 6 people could have infertility in some moment of their lives. That means that we have a lot of people with this problem. We have a lot of couples with infertility, and that is important to understand the impact that this condition could have in the general population. Okay, let's talk about the main steps for ovarian stimulation. And I can give you 5 steps for this process. What is the first one? We need to do a pre-evaluation of the patient before to start the stimulation. The second step is to establish the ovarian stimulation protocol. The third is selecting the medication for blocking the LH surge. The fourth is to choose the ideal medication for triggering the maturation of the oocytes. And finally, the fifth is define if the cycle will have fresh embryo transfer or freeze-all. Okay, first step, pre-stimulation evaluation. Remember that before to start the medication of a patient, it's very important to be sure about the ovarian reserve of the patients. And we have 2 main tools for do that. The first one is the AMH in the left of the screen, and the second one is the antral follicle count in the right part of the screen. If you see the criteria in these both tests, you will find that there is important classification about the patients. You can have a patient with a high ovarian response or poor ovarian response. And it's very important because according to this information, you can select and you can choose what is the ideal protocol for start the stimulation of the patient. There is a threshold and it's the same point for AMH and antral follicle count. If you see here, if you have 15 oocytes or more, you will have a high risk for having a high responder patient. By the other hand, if you have 4 oocytes, you will have a poor ovarian reserve or a risk for obtaining at least a low number of oocytes during the stimulation. And the numbers are equal for AMH and AFC. And the conclusion is that for predicting the response of the stimulation, the AMH and the antral follicle count maybe are the best tools that we have right now over other ovarian reserve tests. What are other interventions that we can do before the stimulations? We can use, for example, progesterone, or we can use estrogens or GnRH antagonists. In some protocols, you will find that these medications could be theoretically useful for the treatment, but the evidence shows that there is no difference if we use some of these medications before the stimulation. But there we have here a very, very useful tool, and is the contraceptive pills before the ovarian stimulation. And what is that? You know that we have a lot of patients that are coming to our clinics from other countries or other cities, and it's very useful for the doctors that are sending to us the patients to use the contraceptive pills before the beginning of the stimulation, because that could give us the advantage for scheduling the beginning of treatment. For example, if the patient wants to come to Colombia in a specific week or a specific month, the doctor can give to the patient contraceptive pills before the ovarian stimulation, and that could be very, very useful for you. Second step, to establish the ovarian stimulation protocol. And here, we must do a rating of these patients in 3 groups: high responders, normal responders, and poor responders. And that is very important because according to this stratification, you can select what is the best stimulation protocol that you can use. In the first group, high responders, you can use antagonist or you can use agonist for the blocking of the LH surge. And it seems at some point that the antagonist could be a better option comparing with the agonist, because you will have a higher risk of hyperstimulation when you use agonist. That is the reason because we prefer the GnRH antagonist in this type of patients. In some moment, we used letrozole and clomiphene for theoretically improving the response of the patients, but finally we know that there is no difference between oral inductors of the ovulation versus gonadotropins. We prefer to use agonist or antagonist and gonadotropins and not oral medications. The low dose of gonadotropins are preferred versus high dose, obviously, because in this specific group, we want to have a normal response, no high response, and that's the reason because we prefer to use low dose of gonadotropins. The second group is the normal responders. In this group, also, we prefer antagonist versus agonist, considering the safety of the treatment and the results, and also because maybe the treatment is more comfortable for the patient because we will use less injections compared with the agonists. To add letrozole or clomiphene to the treatment, that will be the same result. That is not recommended in these patients. And normal or high dose of gonadotropins are preferred in this patient because we want to have a lot of effects in this group. Finally, the poor responders. And remember that this is the group of patients with less number or low number of oocytes. There is no difference using GnRH antagonist or agonist. That is what the evidence showed to us. But some studies show benefits with agonists, but it's not conclusive because, the agonist could give us the flare-up effect, and theoretically we can have more oocytes if we use agonists. But the evidence, I insist, is not conclusive about this topic. If we add clomiphene or citrate or clomiphene citrate, there is no difference. Letrozole doesn't improve the results, but some studies show that clomiphene could be a little useful in these patients. And finally, this is very important, the dose of gonadotropins is very important because in some areas or some countries around the world, some people recommend to use 400 units or 500 units, and that is not true. If we use 300 units is enough for having the same response in any patient. Then, now appears other question about the types of gonadotropins. Is one better than the other? And you will find a lot of information about this topic, but I can give you these 4 sentences. But in summary, there is no difference between FSH, recombinant, or urinary compounds, or HMG, in terms of number of oocytes, fertilization rate, and implantation rate. Pregnancy rate is very similar between one gonadotropin and the other. Letrozole and clomiphene don't show advantages versus gonadotropins in high complexity treatments. That means that we prefer to use only gonadotropins in these treatments. But in some publications, you can find some certain advantage when using LH in patients of 35 years or more. But that is not conclusive, but that could be maybe a personal recommendation. When I do a stimulation of a patient of 35 years or more, I prefer to use LH because there is some evidence that shows that we can have more maturation rate and more quality effects when we use LH. This is my personal advice for you. Third, we need to select a medication for blocking the LH surge. And we have these 3 options. We can use agonists, antagonists, or progesterone. The agonist is less used today. There are a few controversial indications, for example, in poor responders, considering the flare-up effect. But if you decide to use it, please opt for long protocol. It means that you should start the agonist in the middle luteal phase in the previous cycle to the stimulation. The second group, and maybe this is the most common medication that we use for the blocking the LH surge, and it's the antagonists. It's recommended over agonists because their efficacy and higher safety comparable with the agonist, but is more comfortable, less injections, and the final result is very similar. And finally, there is the recent option, and is progesterone, just tablets or pills. You can use pills for blocking the LH surge, but there is lack of evidence because we are using progesterone maybe from 4 or 5 years ago, no more than that. But if applied the progesterone, they can only be used in non-fresh transfer cycles because obviously the progesterone could give us a negative effect in the growth of the endometrium, and that's the reason because we prefer to use progesterone in all the cycles that are not considering the fresh embryo transfer. Fourth step, we need to choose the ideal medication for the triggering or the trigger of the oocyte maturation. And we have two options here. The first one is the HCG. It's the classic medication that we have been used for a lot of years. And we have two compounds, recombinant and urinary HCG. And the second one is the GnRH agonists. What about the HCG? There are no relevant differences between recombinant and urinary HCG. You can use 5,000 units, and that is enough for obtaining a good maturation rate, and is more safe compared with 10,000 units. By the other hand, the GnRH agonists are indicated for diminishing the OHSS risk in high responders, because the HCG is the main compound that could cause the hyperstimulation. The agonists give us protection for this effect. It's not recommended for normal responders and fresh embryo transfer. And there is emerging evidence that shows that the use combined with HCG, that is named dual trigger, could be useful in poor responders. Okay, and finally, the fifth step, define if the cycle will have fresh embryo transfer or if the cycle will goes to freeze-all. And we have some advantages comparing one option with the other. What about the fresh embryo transfer? We prefer to do the fresh embryo transfer when we have low risk of OHSS, if we have 18 follicles or less, if we have a normal endometrial thickness, it means a normal develop of the endometrium during the stimulation, low progesterone levels on Twitter day, and usually we try to have a limit in 1 nanogram or less. There is the threshold for this criteria. And when we don't have indication for PGT. By the other hand, when we prefer the frozen transfer, if we have some type of risk for having any type of OHSS, when we have 18 follicles or more, if we have an abnormal endometrial thickness, if we have high progesterone levels on trigger day, and finally, if we have some indications for do PGT. And remember that when we know previous to the beginning of the treatment that the patient will go to a frozen embryo transfer, maybe the progesterone for blocking the LH could be the best option. There are other relevant topics that I want to share with you today, and it's the luteal phase support. And there is a strong evidence that show that the use of progesterone during these cycles improves the pregnancy rate and the results. Then my recommendation is in all the cycles of IVF and ICSI, you should use progesterone for improving the results. But there is a new concept, and it's the random start. What is that? That means that we can start the stimulation at any moment of the cycle. In the past, we thought that we need to start the medication and the stimulation only at the beginning of the cycle during the menstrual bleeding. But right now, we know that we can start the stimulation at any point of the cycle. And that could be useful, for example, in oncological patients, because that patients need to start very fast the chemotherapy or the surgery. And the oncologists are sometimes very, very concerned about the the postpone of the treatment, but we know that we can start a random stimulation at any point of the cycle, and that could be a useful tool in this type of patient. And remember, please, that we must keep in mind in all of the stimulation cycles that the OHSS is a real risk, and we need to be sure about to identify the patient in risk, and we need to apply all the strategies for avoid the risk of OHSS. That's important to remember today. Okay, that is the information that I want to share with you today, and I hope that all of this lecture will be useful in your routine practice. Have a nice day, and I will be here for any doubt that you can have about this topic. Have a nice day.
Hello. Thank you for attending this international virtual symposium organized by INSER. Today, I will be talking about ovarian stimulation for cancer patients for the purpose of fertility preservation. Cancer remains a public health problem worldwide that also affects young adults. Given the ongoing improvements in survival for most malignancies, a significant proportion of people affected by cancer face the consequences of treatment-related side effects. Therefore, at the time of diagnosis, a significant proportion of young patients are concerned about the possible impact of anti-cancer treatments on their infertility, on their future fertility, and future chances of having a baby. So today I would like to discuss oncofertility counseling for cancer patients, oocyte cryopreservation for the purpose of having a baby in the future, standard versus alternative controlled ovarian stimulation protocols in cancer patients, and finally, the impact of pregnancy and controlled ovarian stimulation on the overall survival and recurrence-free survival rates in cancer patients. So all cancer patients of reproductive age should receive a complete oncofertility counseling as early as possible in the treatment planning process. And this is regardless of the type and the stage of the disease. So first of all, the oncologist should discuss with the patient the gonadotoxicity of the planned anti-cancer treatment, taking into consideration the patient's age and the ovarian reserve markers, and that way determine the patient's particular risk of ovarian insufficiency after treatment. Premature ovarian insufficiency is defined by the loss of ovarian function, and it's indicated by the presence of amenorrhea or oligomenorrhea for more than 4 to 6 months, together with biochemical markers confirming ovarian insufficiency, such as a high FSH and a low estradiol level for at least 2 times, at least 4 weeks apart in women before the age of 40. However, after cancer treatment, many patients experiment temporary amenorrhea that usually reverts in the first 12 months, sometimes even 24 months after gonadotoxic therapy. However, some patients will enter permanent amenorrhea. Regardless of whether this amenorrhea is permanent or temporary, all patients will have a diminished ovarian reserve compared to pre-treatment parameters, and all will have an increased risk of having a premature menopause. So ovarian insufficiency, the risk of ovarian insufficiency after gonadotoxic treatment is classified in 4 groups. Some cancer treatments have no known effect on the ovaries or the gonads. Other anti-cancer treatments are considered low risk, and that means less than 20% chance of having a premature ovarian insufficiency. When the risk is between 20 and 80%, the risk is considered medium, and when this risk is above 80%, the risk is considered to be high. And this will depend on the combined effect of factors such as the woman's age and the baseline ovarian reserve, her diagnosis, and the treatment protocol. That includes not only the cumulative dose of whatever treatment is chosen and the overlapping therapies over a given time period. So once the doctor, the oncologist, has discussed with the patient her individual risk of ovarian insufficiency, he must discuss with the patient her current or future fertility desire, regardless, again, of the type and the grade of cancer. And all those patients with a potential interest in fertility preservation should be referred immediately to a fertility specialist or a fertility clinic in order to define and proceed with a fertility preservation strategy. Both oocyte or embryo cryopreservation are clinically validated techniques with very reproducible cryosurvival and pregnancy rate in post-pubertal females. This technique cannot be applied to children before puberty. However, oocyte cryopreservation does have some advantages over embryo cryopreservation because it does not require a partner, and this can be an important issue for women without a husband or a committed partner who do not wish to use donor sperm. And also, it is associated with less legal or ethical dilemmas over the disposal in the future of unused orphaned embryos. However, both oocyte and embryo cryopreservation require controlled ovarian stimulation, and the classic controlled ovarian stimulations imply the administration of gonadotropins on a daily basis as of day 2 or 3 of the menstrual cycle, followed by the co-administration of GnRH analog in order to suppress the LH surge, and finally a trigger shot to induce oocyte maturation once the leading follicles are around 18 or 20 millimeters in diameter. This whole process usually takes around 12 to 14 days, that is around 2 weeks. And the whole idea is to promote the growth of not just one follicle, as is the case in a natural cycle, but the growth of at least 12 or 15 oocytes, if possible, even 20 oocytes. The more, the better, up to a given point. And that is because age and ovarian reserve are determining factors for success. In other words, age affects quality, and the ovarian reserve, the ovarian response, or the amount of oocytes that can be retrieved. This retrospective multi-center study of vitrification cycles for fertility preservation for various reasons, and on the warming cycles of the women who return to attempt pregnancy over an 11-year period, using this Kaplan-Meier plot of cumulative probability of live birth, shows that the possibility of a critical live birth is basically the same regardless of the indication for fertility preservation. And in the blue curve, we see patients that cryopreserved because of they wish to have what we call an elective fertility preservation process or just planned fertility preservation process without a real clinical indication. And in red, we have patients that had fertility preservations because they had endometriosis of the ovaries. And then in the green curve, we have the patients that cryopreserve because of cancer reasons. We can see that given the use of a similar amount of oocytes in women categorized according to age, the probability of having a baby over time is basically the same for the three same groups. That is, if a woman thaws around 10 oocytes, the probability of having a baby would be around 40%. But if these young women actually can use up to 20 oocytes, then the probability of having a baby over time would be around 80%. However, in women over the age of 35, that is 36 and over, the probability of having a baby after thawing 10 eggs would only be around 25%, and after the thawing 20 eggs, the probability would only be around 60%. Therefore, age is a very important parameter with regards not only to oocyte survival, but the probability or cumulative live birth rate over time. Classic ovarian stimulation protocols, as the one we just discussed, are associated with elevated estradiol levels. These can be up to 10 to 20 times higher than that of a natural cycle. Also, a possible delay of even 4 weeks to start the ovarian stimulation process, depending on the day of the menstrual cycle that the patient first consults. Therefore, having to wait sometimes 3 or 4 weeks till the second or third day of the next menstrual cycle. And finally, there can be an additional delay of around 2 weeks in case of ovarian hyperstimulation syndrome, that is a very high response where we would have to wait for the ovaries to shrink back to their original size before starting the cancer treatment. These can be especially troublesome for young women with breast cancer. Breast cancer is the most commonly diagnosed cancer in young adults aged 30 to 39 years. About 10% of breast cancer diagnoses are in women under the age of 45. And about 2/3 or 2 out of 3 breast cancers are hormone receptor positive. In other words, for these women, having the high estradiol levels associated with ovarian stimulation can be quite troublesome because of the fear that these cancer cells might proliferate under the effect of estrogens. Also, hormone receptor positive cancer patients usually undergo what we call endocrine adjuvant therapy after surgical removal of the tumor in 5 to 10 years. And this will be an additional age-related decline in the ovarian reserve, in addition to the gonadotoxicity of whatever treatment was used. Finally, nowadays, neoadjuvant therapy, that is chemotherapy before the surgical removal of the tumor, is being extended to localized disease, especially in young triple-negative or HER2 early breast cancer patients, and occasionally as well, around 6% of hormone receptor positive early breast cancer patients. So these are issues to consider when thinking about fertility preservation in these breast cancer patients. Finally, about 12% of young breast cancer patients carry a germ-like pathogenic variant called BRCA1 or BRCA2. These patients require additional counseling due to the negative impact on ovarian reserve and the fertility potential, increased risk of ovarian cancer, and even having sometimes to consider risk reducing bilateral salpingo-oophorectomy at a young age. And finally, the possible transmission of the pathogenic variant to the offspring. So it is the need to design alternative controlled ovarian stimulation protocols adjusted to the needs of these young cancer patients was evident. One such alternative or protocol considers the co-administration of aromatase or SERMs along with the gonadotropins during the ovarian stimulation process, with the idea of either reducing the estrogen levels in the case of aromatase inhibitors to concentrations similar to that of natural cycles, or the use of SERMs such as tamoxifen in order to block the effect of estrogens at the breast receptors. A recent meta-analysis, including 11 cohort studies and over 2,000 women, comparing the safety and the efficacy of controlled ovarian stimulation with or without letrozole for fertility preservation purposes, where the primary endpoint was the number of mature oocytes retrieved, observed that the addition of letrozole to controlled ovarian stimulation was associated with a significant decrease in the peak estradiol level, but with no impact at all on the number of mature oocytes retrieved, as we can see in this meta view here, with a mean ratio of 1. Also, two recent randomized trials compared the effect of tamoxifen or letrozole on the number of mature oocytes retrieved compared to the standard ovarian stimulation protocols. In the first of these randomized studies is a single institution study that included 96 women with estrogen receptor positive breast cancer that were randomized to two treatment groups, one receiving standard controlled ovarian stimulation plus 20 milligrams of tamoxifen, and the other group with the addition, instead of tamoxifen, of letrozole 5 milligrams. The results were compared to those of a group of patients with estrogen receptor negative breast cancer undergoing standard controlled ovarian stimulation. And the second is a multi-center randomized trial that included 162 women with breast cancer, regardless of the estrogen receptor sensitivity, that were randomly assigned to three groups. One in which tamoxifen 60 milligrams was added to the controlled ovarian stimulation. A second group had letrozole 5 milligrams added to the standard stimulation process. And the third group just received the standard stimulation with 225 units of FSH under the AGNRH AGA antagonist protocol. And what the two studies showed is that there was no difference in the mean number of mature oocytes retrieved in the three, when comparing the three groups. And finally, what is very interesting is that the peak estradiol level was significantly lower in the group that received controlled ovarian stimulation with letrozole group. That is, in both studies, the mean estradiol level for this group was 642 picograms per ml compared to 2,500 for the tamoxifen and the standard group. And very similar results were found in the second study, where the estradiol levels were 490 picograms compared to 1,662 and 1,546 for the tamoxifen and the standard stimulation groups. The second ovarian stimulation alternative protocol is what we call random start protocols, where the stimulation process is initiated immediately after the patient's consultation. And this contrasts with this conventional start, where the gonadotropins are only started on the second or third day after withdrawal bleeding or the menstrual cycle. In random start cycles, then gonadotropins are started after the initial visit, regardless of whether the patient is in the late follicular phase, that is phase 5, 6, or 7 of the menstrual cycle, or 10, or in the late or in the luteal phase after ovulation. It's always 2 or 3 days after the patient's initial visit. And what this systematic review and meta-analysis of 10 studies shows that was recently published and that included 1,653 cancer patients with the purpose of comparing the clinical outcome of random versus conventional start protocols, is that overall the random start cycles were longer, with a mean difference of 0.7 days, used more gonadotropins with a mean difference of 248 units than standard control or ovarian stimulation cycles. However, there was no difference among the two groups in the number of mature oocytes retrieved and in the number of cryopreserved embryos. In other words, they're both clinically comparable, except for being the random start being at 1 day or less than 1 day longer. And finally, the third alternative ovarian stimulation protocols use administered progestins instead of GnRH antagonists to prevent the premature LH surge. This is basically a cost-reducing strategy, I would say, and also used always GnRH analogs to trigger oocyte maturation instead of using ACG in order to prevent ovarian hyperstimulation syndrome, which would delay the start of anti-cancer treatment. So finally, I would like to review a couple of recent studies evaluating the safety of pregnancy and the alternative controlled ovarian stimulation protocols after breast cancer regarding the time to initiate cancer therapy, the disease-free survival, and the overall survival of these patients. So this review published this year by the European Society of Medical Oncology that included 3 matched cohort studies evaluating the time to start NAT or neoadjuvant therapy in hormone receptor positive breast cancer patients, observed that only one of the 3 studies reported a significantly but very small delay of 10 days to start NAT in the cohort study undergoing ovarian stimulation compared to the control groups. The authors considered that this delay, if any, is modest and clinically trivial. They also included 6 cohort studies assessing the survival outcomes in these patients, and they observed no increased risk of recurrence or death after a follow-up period that ranged between 3.5 to 6.9 years in the different studies after controlled ovarian stimulation in women referred to NAT or with hormone receptor positive breast cancer. There was no data on the safety of controlled ovarian stimulation in patients that were both hormone receptor positive or undergoing NAT. So the authors again conclude that being referred to neoadjuvant therapy or having a hormone receptor positive breast cancer does not constitute per se an a priori contraindication to control ovarian stimulation in women with early breast cancer patients. And what about the safety of pregnancy in these women with hormone receptor positive disease? And this meta-analysis included 8 retrospective cohort studies comparing survival with and without pregnancy in premenopausal breast cancer patients with hormone receptor positive disease. After a median follow-up of 3.8 to 15.8 years, in which 33% of the patients included had a subsequent pregnancy and 66% had no pregnancy, the results show that there's no difference, as we can see in the meta-views, in the disease-free survival between the groups. According to 3 studies that included 987 patients with a hazard ratio of 0.96 for the disease-free survival. And however, which is quite interesting, there was a significantly better overall survival in the group with a subsequent pregnancy, according to a meta-analysis of 6 studies in 3,500 for patients with a pool hazard ratio of 0.46. So this is quite promising, I would say. And with regards of pregnancy in breast cancer patients who are carriers of the pathogenic BRCA variant, this multi-center retrospective cohort study conducted in 78 participant centers worldwide in women aged 40 years or younger who had invasive breast cancer, carrying the variants either BRCA1 or BRCA2, in order to investigate the cumulative incidence of pregnancy and disease-free survival in these young women. Observed that 659 out of 4,732 patients, that is 14% participants, had at least one pregnancy after a median of 3.5 years after the diagnosis of breast cancer. And there was no difference in the disease-free survival between the patients with or without a pregnancy, with an adjusted hazard ratio of 0.99 after a median follow-up period of 7.8 years. And again, the patients who had a pregnancy had a significantly better overall survival. So no negative effect was associated to pregnancy in this subgroup of breast cancer patients either. This same study group also evaluated the safety of doing controlled ovarian stimulation and IVF to achieve a pregnancy versus natural conception in this subset of breast cancer patients who were carriers of the BRCA gene, and observed that out of 543 patients who had a pregnancy, 80% after natural conception and 20% after IVF, there was no difference in the disease-free survival between the two groups after a mean follow-up of 9.1 years. So neither IVF nor pregnancy were associated with an increased risk of recurrence or death. Finally, I would like to review this trial called the POSITIVE trial that was recently published in the New England Journal of Medicine, which stands for Pregnancy Outcome and Safety of Interrupting Therapy for Women with Endocrine Responsive Breast Cancer Trial. This is an international, multi-center, prospective trial conducted by the International Breast Cancer Study Group in 20 countries around the world. And it was designed to evaluate the safety of interrupting endocrine therapy after breast cancer, and it included patients aged 42 years or younger with breast cancer stages 1 to 3 who received adjuvant endocrine therapy for at least 18 to 30 months and discontinued the therapy for only a maximum of 2 years in order to expose themselves to a pregnancy, carry out the pregnancy, and breastfeed. And the results are that out of a total of 518 patients who discontinued this endocrine adjuvant therapy after a mean time of 29 months after cancer diagnosis, the cumulative incidence of breast cancer-related events was 8.9 and 9.2% in the endocrine treatment interruption group versus the extended control group after a 3.4 years of follow-up. So there was no evidence of any detrimental effect of interrupting the temporary interruption of the endocrine therapy. And they also decided to evaluate whether undergoing controlled ovarian stimulation and IVF in this same cohort of patients would affect survival. And what they found is that after interrupting the endocrine therapy, 497 cancer patients resumed menses within 12 months. And out of these, 179 patients that had undergone controlled ovarian stimulation and fertility preservation at the time of cancer diagnosis. 68 had a subsequent embryo transfer. And the cumulative 3-year incidence of breast cancer-related events after discontinuing this adjuvant endocrine therapy was similar between the group of patients who underwent controlled ovarian stimulation or not. And finally, out of 368 patients who reported a pregnancy, it was evident that those who underwent fertility preservation and embryo transfer had a much higher conception rate with an odds ratio of 2.41. So I would like to conclude by saying that despite the general perception of iatrogenic infertility as one of the major concerns among young breast cancer patients, the number of those seeking fertility preservation before undergoing systemic cancer therapy is very low, around 10%. And so what we do need to do is to generate awareness about the risk of premature ovarian insufficiency after anti-cancer treatment and the feasibility and the safety of fertility preservation in young post-pubertal patients with cancer, especially breast cancer stages 1 to 3. An efficient network then between the oncologist and the fertility unit must be established in order to initiate these fertility preservation treatments in a prompt manner. Thank you for your attendance.
Hello, everybody. I am Dr. Susana Salazar, OBGYN, and specialized in fertility. Simplex and distinguished guests, it's a great honor to be here with you today at this prestigious international symposium. As a specialist in reproductive medicine, I am excited to share insights and advancements of the topic of luteal phase support, a crucial aspect of reproductive care that can profoundly impact patient outcomes. Thank you for the opportunity to be part of this important dialogue. Let us embark on this journey of knowledge together. But what is the luteal phase? It is a period of time between the transformation of the dominant ovarian follicle into the corpus luteum, shortly after the ovulation, and the establishment of pregnancy or the beginning of the menstrual period. During the luteal phase, levels of progesterone and estrogens rise to prepare the uterine lining for the implantation. Maintaining adequate hormone levels is crucial for successful embryo implantation and early pregnancy development. Timing and duration. The luteal phase typically lasts around 12 to 14 days, with any significant deviation potentially indicating a luteal phase deficiency, which can negatively impact fertility. The secretory activity of the corpus luteum is maintained by the pulsatile secretion of the luteinizing hormone from the pituitary gland. However, each corpus luteum has a scheduled lifespan beyond which LH support is not sufficient for its maintenance. In the absence of pregnancy, luteal phase ends with a loss of the functional and structural integrity of the corpus luteum, known as luteolysis. If pregnancy is established, the corporal life of the corpus luteum is extended by the process called corpus luteum rescue. This process requires sufficient amount of human chorionic gonadotropin, HG, secreted by the early implanted embryo. What's important of the luteal phase support? First, implantation. Adequate luteal phase support helps create a favorable uterine environment for embryo implantation, increases the chances of successful pregnancy, Second, early pregnancy maintenance. Maintaining proper hormone levels during the luteal phase is crucial for the continued development and survival of the pregnancy. 3. Improved fertility outcomes. Providing an appropriate luteal phase support have been shown to enhance the successful rate of assisted reproductive treatment such as IVF. And 4. The patient experience. Effective luteal phase management can improve the patient experience by reducing the risk of early pregnancy loss and providing more supportive environment for the embryo implantation. Now I want to talk about the hormones involved in the luteal phase. We already talked about the progesterone that is produced by the corpus luteum. Progesterone is essential for preparing the uterine lining for the implantation and maintaining of the pregnancy. Second, the estrogen. Estrogen levels also rise during the luteal phase, working in conjunction with progesterone to support implantation and early fetal development. HCG, the human chorionic gonadotropin, is produced by the placenta and helps maintain the corpus luteum, ensuring continued progesterone production. And fourth, LH, luteinizing hormone, triggers ovulation and also plays a role in the formation and function of the corpus luteum during the luteal phase. Now let's talk about the diagnostic and evaluation of the luteal phase. One of those is the basal body temperature. Tracking the basal body temperature can provide an insight into the ovulation and the length of the luteal phase. Second, the hormone testing. Blood tests to measure progesterone, estrogen, and other hormones can help assess luteal phase function. For example, measuring progesterone day 21 to 22nd of the menstrual cycle, it's very important to know if the patient has ovulated before. Endometrial biopsy. In some cases, an endometrial biopsy can be performed to evaluate the uterine lining and confirm the presence of the luteal phase defect. And also, imaging studies, techniques like transvaginal ultrasound can be provided to access the corpus luteum and also monitor changes during the luteal phase. Which are the common luteal phase deficiencies? First, insufficient progesterone. An inadequate progesterone production by the corpus luteum can lead to a suboptimal uterine lining and increased risk of implantation, failure, and early pregnancy loss. Other is shortening luteal phase. A luteal phase that is shorter than the typical 12 to 14 days can also compromise the uterine environment and reduce the chances of successful implantation. Another one are the ovulation disorders. Underlying conditions can affect ovulation, such as PCOS, polycystic ovarian syndrome, can disrupt the normal luteal phase and contribute to fertility issues. And inadequate corpus luteum, factors like advanced maternal age or previous ovarian surgery can impair the formation of the corpus luteum, leading to luteal phase deficiencies. Let's talk about the symptoms of luteal phase deficiencies. Irregular menstrual cycles. Patients with luteal phase deficiency may experience shorter or more irregular menstrual cycles, as the corpus luteum plays a crucial role in regulating the menstrual cycle. Another one is spotting or bleeding. Inadequate progesterone production can lead to spotting or light bleeding during the luteal phase, which can be an indication of luteal phase defect. Another, infertility or recurrent pregnancy loss. Luteal phase deficiency is a common cause of infertility and can also contribute to an increased risk of early pregnancy loss, as the uterine environment may not be optimal for embryo implantation and development. Now let's talk about luteal phase support strategies. Luteal phase deficiency is a common result of assisted reproductive technologies, ART, characterized by inadequate or inappropriate progesterone production. This inevitably compromises the successful establishment and maintenance of pregnancy and has led to the critical requirement for luteal support protocols. Luteal phase support in IVF. The provision of exogenous progesterone to supplement endogenous progesterone production has become a routine component on ART. The wide variation in clinical approach means that the choice of luteal-free support for couples undergoing ART is far from clear. Evidence suggests that current global preference for luteal-free support via vaginal progesterone in tablet forms administered for the day of the ovulation collection and maintained for 8 to 10 weeks. The medication we usually use for the luteal-free support are free progesterone, HCG, GnRH agonists, and also estrogen. Synthetic progesterone or natural micronized progesterone are commonly used to supplement the luteal phase support and implantation in every pregnancy. HCG, human chorionic gonadotropin, can be administered to stimulate the corpus luteum and maintain progesterone production during the luteal phase. GnRH agonists, gonadotropin-releasing hormone agonists, may be used to support the corpus luteum and prevent premature luteal phase deficiency. When we talk about luteal phase support in IVF patients, we must ask ourselves the following questions. First, route of administration. Second, time to common supplementation. Another one is duration of the progesterone supplementation. Because although it is clear that exogenous luteal phase support improves the rate, there has been significant debate and research regarding timing, dose, and routes of progesterone administration. With regard to the timing of progesterone initiation, there is endogenous progesterone production from the corpus luteum after HCG triggering that persists until 5 to 6 days after oocyte retrieval. Therefore, it's likely that progesterone supplementation should be initiated before the day 5 to 6, but it is not clear how early should progesterone be initiated before the decrease of the endogenous progesterone. It has also been proposed that early progesterone administration may be of benefit before the embryo transfer by the smooth muscle relaxing effect of the progesterone in the uterus. The question is, does progesterone supplementation improve clinical pregnancy rates in women undergoing fresh IVF cycles? This meta-analysis published by Fertility and Sterility in 2019 showed there was a significant benefit to clinical pregnancy rates of either the route of progesterone supplementation compared with no supplementation. Numerically, it was equivalent to increasing mean pregnancy rate from 14 to untreated women to 30.7 after oral, 36.4 after vaginal, 36.6 after subcutaneous, and 44 after intramuscular progesterone supplementation. Let's talk about oral progesterone. The routes of progesterone administration exhibit different pharmacological profiles. Oral progesterone has very poor bioavailability, does not produce a sustained plasma progesterone concentration, and fails to elicit an adequate endometrial secretory response, and also produces sedative metabolites. In addition, a negative impact on implantation was observed after oral micronized progesterone versus intramuscular or vaginal. Administration of the orally effective dihydrogesterone led to clinical pregnancy similar to those after vaginal micronized progesterone support. Recent evidence also suggests that oral dihydrogesterone is well tolerated and is not associated with significant fetal or maternal sleep risk. Despite this, oral progesterone has very low current clinical issue. So, oral micronized progesterone for luteal phase support in ART not only results in significantly lower rates for pregnancy and implantation compared with those for intramuscular HCG progesterone, but also causes more side effects. Administration of the orally effective dihydrogesterone led to clinical pregnancy rates similar to those after intravaginal micronized progesterone support. Now, vaginal progesterone versus intramuscular progesterone, which is best. Vaginal progesterone, there are limited numbers of vaginally administered progesterone preparation, including progesterone capsules of 1, 2, and 400 milligrams natural progesterone, and progesterone gel, 90 milligrams natural progesterone. Intramuscular progesterone. Two recent meta-analyses, including a prospective randomized trial, also indicate that intramuscular progesterone confers the most benefit compared with oral or vaginal administration. Intramuscular administration of progesterone results in higher, more sustained serum levels than vaginal administration. However, vaginal regimen undergo rapid absorption to achieve higher endometrial tissue concentrations. The other question is, when do we should start the supplementation? It's more beneficial when it commences between the oocyte retrieval and the embryo transfer. Commencing progesterone supplementation on the day after the oocyte retrieval has more beneficial trends in clinical pregnancy rates. Delaying supplementation until the third day reduces clinical pregnancy rates versus starting the day of the oocyte retrieval. The other question is duration of progesterone supplementation. Several meta-analyses were performed to investigate the impact of extended luteal phase support duration. Now, let's talk about the duration of the progesterone supplementation. Several meta-analyses were performed to investigate the impact of extended luteal phase support duration. In 2012, Liu et al. Published a meta-analysis of 6 randomized controlled trials. No difference were detected between the patients who underwent early and late progesterone cessation in terms of live birth rate and ongoing pregnancy rates. A Cochrane review found similar results. Recent guidance, ESRI, recommended that progesterone for luteal phase support should be administered at least until the day of the pregnancy test. A close look at 4 such surveys conducted over the last decade reveals that the majority, more than 60% of clinicians worldwide, administer luteal phase support until 8 gestational weeks and beyond. This rate did not change significantly over the years. Only 24% of clinics in the UK withdraw luteal support at biochemical confirmation of pregnancy. Notably, 40% of clinics reported that they continue luteal phase supports until 12 weeks of gestation. Clinicians will be confident that they comply with the principle of premium non-share, or first do not harm, before introducing a routine of early luteal phase support withdrawal. Now talk about the doses. This table taken from the ESRI guidance, where they explain the different doses according to the rules of administration. The dosing of natural progesterone has evolved empirically. Usually those include 50 milligrams once daily for intramuscular progesterone, 25 milligrams once daily for subcutaneous progesterone, 90 milligrams once daily for vaginal progesterone gel, 200 milligrams 3 times a day for micronized vaginal progesterone, this is what we use, 100 milligrams 2 or 3 times a day for micronized vaginal progesterone in starch suppositories, and 400 milligrams 2 times a day for vaginal progesterone. So which are the luteal phase support strategies? Medication, we already talked about the progesterone. Hormonal therapy, other medications used as estrogen and HCG to support the function of the corpus luteum and promote progesterone production. Lifestyle medication, adjustments to the diet, stress management, and other lifestyle factors to optimize hormonal balance and nutrient receptivity. And assisted reproductive technologies. The incorporation of luteal phase support strategies into the reproductive treatments such as IVF to enhance the chances of successful implantation and pregnancy. Another question is it beneficial to add estrogen or HCG to the luteal phase support? Estradiol role. The role of estrogen production by the corpus luteum is rather complex. Animal studies have demonstrated that the direct injection of estradiol into the ovaries induces luteolysis, probably due to prostaglandin overproduction. Estradiol priming is essential for the synthesis of progesterone receptors and progesterone-induced changes in the endometrium after ovulation. Estradiol controversy. The role of estradiol during the luteal phase of ART cycle remains controversial. Although some studies reported improved rates of pregnancy and implantation, other studies have not found any beneficial effect on adding estradiol barrier to progesterone for luteal phase or in DNRH antagonists. The cover meta-analysis mentioned before reported no difference in live birth rate and ongoing pregnancy rate, no ovarian stimulation syndrome between progesterone with estradiol supplementation and progesterone alone. In RCT, more recent than that meta-analysis, including 220 women, compared progesterone and progesterone with estradiol for luteal phase support, and reported no significant difference in ongoing pregnancy rate, 32 versus 36%. In contrast, our RCT not included in that meta-analysis investigated the effect of adding estradiol to high doses of progesterone in 240 women, and reported significantly higher clinical pregnancy rates with estradiol supplementation in women undergoing of long DNRH antagonists and short flexible DNRH antagonist protocol. The recommendation of ESHRE is the addition of estradiol to progesterone for luteal phase support is probably not recommended. The justification is the data suggests that estradiol is not recommended for luteal phase support since it does not improve efficacy in terms of labor rates, pregnancy rates, or safely in terms of ovarian hyperstimulation syndrome. Is it beneficial to add HCG during the luteal phase? HCG is equal to progesterone protocols regarding efficacy. However, HCG increases the ovarian hyperstimulation syndrome risk, specifically in high responders and with the dosage historically used, 1,500 units. Studies compared HCG and progesterone for luteal phase support have not been stratified according to ovarian response. ESHRE recommendation is in HCG-triggered ovarian stimulation syndromes, HCG as luteal phase support in standard dosage of 1,500 units is probably not recommended. So these are the conclusions and the key takeaways. Importance of the luteal phase. The luteal phase is a crucial period for successful implantation and early pregnancy maintenance in assisted reproductive therapies. Luteal phase deficiencies, common luteal phase deficiencies such as inadequate progesterone production or shortened luteal phase can negatively impact fertility and pregnancy outcomes. Diagnostic and evaluation. A comprehensive diagnostic evaluation, including hormone testing and imaging studies, is necessary to identify the obvious luteal phase defects. Luteal phase support strategies. Effective luteal phase support strategies, including medication, hormonal therapy, and lifestyle modification, can significantly improve the chances of successful in assisted reproductive treatments. Progesterone is recommended for luteal phase support after IVF-ICSI. The administration routes, any administration route not oral, for natural progesterone can be used to pregnancy outcomes. Starting progesterone for luteal phase support should be in the window between the evening of the day of the ovulatory retrieval and 3 days post-ovulatory retrieval. And how we know progesterone for luteal phase support should be administered at least until the date of the pregnancy test. We prefer to administer it for more than 8 weeks. Thank you again for joining us at this symposium. I hope you enjoyed this presentation.